Thank you, sir. Moving on to the next session. We are privileged to have Dr. A. Gopalakrishna Gokhale, sir, a senior cardiac surgeon who is currently serving as the Director of Heart and Lung Transplant at Apollo Hospital, Hyderabad, a distinguished cardiac surgeon with more than 30 years of experience. He was the first in India to perform
The patient gets care round the clock. Very impressive. Those days where there is not much money in private practice, but he never compromised in the quality of care. I think that keeps him apart from everything. And good, he's a role model to many people around here. I'm yet to see anyone beating that sort of services around. Now, having said that, I've been asked to talk about responsibilities and rewards of cardiac surgery. The previous speakers, the eminent speakers, have spoken about the past, present, and all the development that happened over a course of time. And Dr. Prasad Rao Garu elegantly spoke about future of cardiac surgery. You know, there are so many wonderful things are being done in the field of cardiac surgery. Now, we are talking about cardiac surgery, but my speech is about the person behind the cardiac surgery, the cardiac surgeon, because the responsibilities and rewards of cardiac surgery. Cardiac surgery is an absolute thing. How is it going to have a responsibility? The people behind it who take the responsibility to make sure the cardiac surgery delivers only the best for the people who are in need. Has it changed? No? How do I change it? Okay. Thank you so much. See, cardiac surgery is a very demanding branch. Many people shy away from it, except for those who are really passionate about cardiac surgery. But of course, these days, fortunately, we are able to get MBBS people before they get caught in the web of materialistic things in the world. Because of their passion, many people are joining. But it's a very rewarding medical specialty. It involves high-stakes decision-making and complex procedures. You have seen so many complex procedures being done in surgery. I know interventional cardiology is growing in leaps and bounds, but then it's going to take some time before it can do all those complex procedures. Ultimately, it is the heart team approach that is going to give the patient the best. Offers unmatched personal and professional satisfaction, but very often at the cost of health and family responsibilities. Now, what are the key responsibilities for a cardiac surgeon in this field? See, we know as a clinician, that is our first responsibility as a clinician. We have to make sure the patient gets accurate patient evaluation and risk assessment. And we need to design surgical plans based on diagnosis. See, initially, as Dr. Gopichan said, when we got trained, it's very simple. Put a star and road valve, or just do close the ASD, or just put vein grafts. But today, the procedure is not that simple. You know, when you want to do a bypass surgery, it's so complicated. Should we do through sternotomy or through the minimal access? Should we use a robo or endoscopic? Should we use a lima or bema or both mammary arteries? Should we use a radial artery? Should we use a Y graft, X graft? All these things, you know, so many things, sequential graft. And every patient, we need to take a decision, think about the patient before we do the procedure. That becomes so complicated. And there are a lot of high-risk procedures that are coming up because, especially working in cities like metros, like Hyderabad, Bangalore, all these peripheral centers coming up, and we hardly get any straightforward cases. Everything is becoming high-risk heart surgery. I'm sure I've seen the wonderful work being done at the Aster Ramesh, those post-MI ventricular septal ruptures, ventricular ruptures. Great work is being done, and situation is even worse in bigger cities. And we have to provide a holistic care, pre as well as intra as well as post-operative care, and we need to develop trust with the patients, families and teams. And apart from all this hard work, to make cardiac surgery useful, we need to stay updated in the knowledge with all the clinical guidelines. It is not just a clinician. A cardiac surgery, if you want to run a good cardiac surgery specialty, you need to work as a leader too. A surgeon has to be a leader. Strategic decision maker in high pressure environments, maintaining calm under pressure, because once the leader loses the coolness, everything is a chaos. And he has to be a mentor and teacher to junior staff because it is an ongoing process. We are here because our teachers taught us, and we need to make our younger generation better than us. Then only we remain as a good cardiac surgeon. We need to drive quality improvement in patient safety. Everything is under the magnifying glass these days. You need to watch that, and we need to lead surgical teams efficiently, make critical ethical decisions. Not that we do. Anyone who has, we see a lot of people come with a severe MR, they ask us, why don't you replace? You cannot, because what we are giving as artificial is no good compared to the nature, God-given valve, and lot of years, decades, these patients can survive with those leaking valves. Provide the proper medical management, and the LV function is good, not direct. There are many things, it's not that anyone who has a severe MR comes and we replace it. And we need to contribute to the growth of the profession. Very, very important part that we don't continue what is happening in the past, but we need to contribute to this. And as a team player, it's a very tough job. Cardiac surgery is so interdependent among other specialties. Nephrologists, of course, forget about cardiology is a part of us. It's like a marriage. I don't talk about cardiology separately because we are one. And we need to work with other specialties like neurology, nephrology, and anesthesiology, all these people. It is a very tough job because everyone needs to be on their toes. The error of margin is very low here, so you need to make sure everyone is on their toes, giving their best, which makes them as enemies to most of the people in the teams. We need to share knowledge and support team learning, and we need to value input from the team members like nurses, technicians, and we need to build a culture of mutual accountability and trust. It is not that only surgeon is responsible. We need to motivate the people to give the best in cardiac surgery. Cardiac surgery alone cannot do anything. We need to have a great team. Only great teams last longer. We need to motivate the people working with us. And apart from that, so much development is happening. AI, you are talking of AI, mind-boggling what is happening. You talk about robotic surgery, mind-boggling what is happening. As Gopichan, as Prasad Rao Garu said, few more years you want to see, even today about 30-40% of our cases don't get sternotomy, but in future probably about 10-15% will get it. Most people would come to a stage wherein they go home in a few days, 2-3 days, just like following angioplasty. But for that, you have to learn. How do you learn? You can't learn everything in the patient. We need to develop models. We need to go attend the conferences, workshops, come here, work on animals. So much work you need to do to make sure that cardiac surgery stays in the forefront. It's not an easy job. And there's so much to learn in these areas. And apart from all these developments, people think, the referral doctors think that these doctors are doing beautiful job, minimal act surgery. But you have to remember, it puts a toll on the cardiac surgeon as a team, bending this side, that side, seeing through a small hole. For doing all that, these people need to stay healthy. We need to maintain physical fitness, endurance for long surgeries. We need to learn about how to manage stress and avoid it. Burnt out, healthy lifestyles, regular checkups. We are no exception. We know of many cardiac surgeons who require procedures. We are no exception. This is only a profession. We have to stay healthy. This is especially important lesson for the younger surgeons who are here. And we need to set a positive example for colleagues, staying healthy and balancing and work and personal life. More is said. Books have been written, volumes have been written. You go into the internet, you can probably download thousands and thousands of pages. Very difficult to practice, but we need to try. Group practice is a must these days. The solo days are gone, and with a solo you cannot give what is best. You can give an average work, but not the best. We need to prioritize time for family, hobbies. We need to set boundaries. We need to learn to delegate tasks to our junior staff. Then only we will survive a longer time. and we need to stay mentally, emotionally well-being, then only we can deliver things. And what are the rewards? It's a lot of hard work we have seen. It's not easy. Even today, see the last week, most of us were in Madurai trying to learn endoscopic surgery. I have never seen endoscope. I have not seen ultrasound machine during my general surgery training. We have come a long way. So we need to learn what is the satisfaction. Witnessing patients recover from life-threatening conditions. Sometimes they get up from deathbed. Some procedures, dissection of aorta, do a sick patient going on transplant now after 10 years, doing his business. These are all wonderful things. People cannot believe how much satisfaction we get out of this by offering what is best. We need to play a key role in turning crucial moments to survival stories. Deep emotional fulfillment. Yes, I have that. Most of us have that. Deep emotional fulfillment, building long-term bonds, and it reinforces the purpose and meaning behind the intense effort, and it is the meaning of our profession. In addition, we have opportunities for innovation research. Financially, it is quite rewarding. It offers meaningful, impactful career, a blend of responsibility and reward unmatched in medicine, I can tell you that. Now I think, this is my last slide, this depicts a real cardiac surgeon and a cardiac surgery, the karma yogi performing duties with the dedication, the service of the needy, and seeking fulfillment in the act of service itself, acting selflessly for the welfare of the patients. And don't forget the discipline, humility, and spiritual strength in daily work. All these things we need to inculcate to offer what is best for any specialty, but in cardiac surgery where there is a very low margin for error, we need to do that. Thank you very much again for Aster Ramesh Hospital for giving this opportunity.
Thank you, Dr. Gokhale, for that excellent advice.
Thank you, sir.
More speakers?
Yeah, one more speaker. Sir, next we have Dr. G. Balasubramani, currently serving as the head of cardiothoracic vascular surgery department and director of heart and lung transplant at Gleneagles Hospital, Chennai. Sir is pioneered in heart lung transplant program in India and has expertise in VATS, minimally invasive cardiac surgeries and robotic surgeries.
So, very good afternoon to all of you.
Over to you, sir.
Okay. So, very good afternoon all of you. In fact, I thought of quitting my talk after hearing the mesmerized talk by Dr. Gokhale sir. In fact, I grew up seeing the legends who are sitting on the dais. And we evolved from 2011, we started our first single lung transplant, and recently we have done our bilateral lobar lung transplantation. And at our center, we have done more than 500 heart and lung transplant. Mostly, almost 70% is a lung and 30% is a heart transplant we do at our centers. So surgically, the topic there is a surgical transplant technique on heart transplant. So either it could be orthotropic or the heterotropic transplantation. Orthotropic usually either it will be a bilateral anastomosis or it will be a bicaval anastomosis we do, depending upon the surgeon choice. So this is a bicaval technique where you anastomose the both SVC and IVC. And this is heterotropic implantation. They do less than 0.3% heart transplant worldwide. And it is beneficial to the patient who has got the pulmonary hypertension that would exclude orthotropic transplantation. And demerits are it's difficult surgery and no anginal relief need for anticoagulation. Contraindicate native heart has the significant tricuspid or mitral regurgitations. So normally we do on the donor aspect we do the standard sternotomy. We take a pericardial sutures and we inspect the heart, especially the patient donors who are above 40 years, to look for any coronary blocks or anatomically if there are any issues are there. And then we give antigrade custodial solution, and then we ventilate either the LA appendage or the LA, and also the SVC or IVC. So we just put the ice trash and then we pack it in 3 layers for containers and put it and transfer in a 10-degree box. So this is how the heart donor procurement is done. So we will dissect on the intrathecal groove to provide adequate right pulmonary artery vein in the LA cuff. Normally we take around 1.5 centimeters. So either it will be transported in ambulance or the charter flights or the domestic flights, depending upon the distance covered. So in the Western countries, they use heart care for transporting the hearts in a warm ischemic phase, so that we can increase the ischemic time with this. But disadvantage is the cost. Each one will cost around 40 to 50 lakhs. So on the recipient side, we do the median sternotomy, and then high aortic cannulation, high SVC and low IVC cannulation. We initiate a CBP and drift into 32 degrees. And we use the CO2 insufflations. And then we transact the IVC leaving 1.5 centimeter. See, if there is there are two disputes happen whenever we harvest the donor heart. One is the IVC level between the liver surgeons and the heart transplant surgeon, because we need to have an adequate IVC cuff. Similarly, whenever there is the lung and the heart is being harvested, you need to have adequate LA cuff so that we can be able to implant without any issues in the recipient transplantation. So normally transcendental decompression will be done with the LA. So we start from the LA side and then IVC and then aorta, the pulmonary artery, IVC, aorta and then SVC. These are we do the anastomosis. So LA anastomosis the proline, fluoroproline, and also aortic, IVC and posterior SVC anastomosis, the 5 proline will be done. So this is the recipient surgery, where the native heart explanted with a beating heart after cross clamping it. So aorta dissected, and always leave the rim of LA, good adequate LA. So we start with the LA to LA anastomosis. Then IVC, PA and aorta, finally the SVC. So there are certain complications will be there, like a bleeding, pre-operation for bleeding and tamponade, primary graft dysfunction, multi-organ failures, stroke, acute kidney injuries. So these are some of the complications. Post-operatively we will follow the triple drug regime. We use, some of the centers they use the induction therapy with the basiliximab, and some centers they may not use it, they just use the solumetrol. So this is our experience over a period of almost 2012 to 2022. So in fact our results are almost at par with the Western countries. So these are recent 22-year-old DCM patients before and after heart transplantation, X-rays. But there are certain challenges. One is the logistic of the organ transport, quality of life after transplantation, rejection, and there are certain hurdles we need to overcome, like organ utilization, late referrals, pediatric organ donations, and lack of heart failure clinics. Thank you.
Thank you very much for that brief. Please join us. We are running very much short of time, I think. I'll give 30 seconds each to some of our moderators who have been sitting patiently. Anybody wants to?
Yeah, really lack of time, but I have a few questions, but it's a wonderful talk given by all the speakers. Really mesmerizing talk by Gokhale sir, because definitely that inspires a lot for surgeons like us. And other really go beyond the scalpel and like a medical engineering, Dr. Balakrishnan sir and Sajja sir. And I have only two questions. One is for Jairam Bhai sir. So what is your protocols? Is it a failed PCA in a acute MI condition is going for a CABG, or triple vessel disease with LMCA disease and anyway needs either a staged PTC or today PCA and later CABG? What is your strategy?
Actually, when angiogram is done, we as a collecting is together and we discuss. We find if it is all the vessels we can comfortably bypass, and it is only rescue angioplasty followed by CBG, we prefer to go for a surgery. And because it is economically viable to the patient, and many patients may not turn out after first procedure, and we have found many patients, few of the patients we are lost while waiting for the after rescue and we are positive waiting for the surgery. So as our results are very good, we don't hesitate. It is like for us now, it has become like elective procedure. Any emergency cases, we directly take up. If entire cardiac team agrees that surgically it is better beneficial than PCA.
Really amazing work, sir. But one more question. For a cardiogenic shock and CABG, is it IABP enough or you require a ECMO background?
Most of the cardiac patients who are getting away with this IABP. Most of the patients are getting away with IABP.
So we won't have enough time for questions and brief comments, anything, 30 seconds, sir, because we have been sitting patiently. My sincere apologies to the eminent panelists, because anybody who has any specific interest, you can meet them across lunch and discuss with them. Well, my glucose sensor is showing very low sugar. Anyway, last comment. Shall we wind up? I think you are also tired. So we'll wind up this session now and
so one small moment to our panelists. Dr. Kumar will. Dr. Subbareddy.
Thank you, sir. Subbareddy. I request everyone to stay back for the felicitation program. I request everyone to stay back for the lamp lighting and felicitation.
ఇదేం ఆపేడు వాళ్ళది
We are absolutely sorry for the delay and we take pleasure
రైట్ చేసిన కూడా
in inviting P. Chandrasekhar Garu, Chief Guest, VC NTR Health University onto the desk.
శుద్ధంగా
Managing Director Dr. P. Ramesh Babu to do the honors. I now take pleasure in inviting Dr. G. Subramani Garu onto the dais. Dr. S. Lokesh on the dais. Dr. A. Gopalakrishna Gokhale Garu, please invited onto the dais, please. Dr. D. Prasad Rao, sir, please join us on the dais. Dr. K.R. Balakrishnan, sir, please join us on the dais. Dr. D. Prasad Rao, sir, please join us on the stage.
పిచ్చిలో కూర్చొని తీసుకోవచ్చు మీరు
Dr. K.R. Balakrishnan, sir, please join us on the stage. So may I request all the guests to please come over for the lamp lighting ceremony. Requesting all the guests to please join.
భయ కొంచెం అటు సైడ్కే ఉండండి, అటు సైడ్కే ఉండండి చాలు. ఎవరు రాజు
May we also have Jairam Pai sir and Suprashad Garu onto the dais, please. Please join us, sir.
Thank you one and all. Please be seated. I request everyone to be seated.
ట్రైపాడ్
Now I invite Dr. P. Chandrasekhar Garu sir to please address the gathering.
ప్రోగ్రామ్
Good afternoon, everybody. Respected the dignitaries from dais, seniors, teachers of the teachers, Dr. Ramesh and fellow cardiologists, general practitioners, and the members of the press. It is indeed a great pleasure for me to be invited for the Fusion 2025 as a chief guest. And as you know that I have taken charge as a Vice Chancellor of Dr. N.T. Health University on April 25th. First time the cardiologist has become a Vice Chancellor of the N.T. Hospital. I know Dr. Ramesh, so since 3 decades. He has been pioneer and we have given also Outstanding Person of the Year award 5 to 10 years, 6 years back, and he has done tremendous for this area. He has contributed a lot, and in fact he has invited me in '98 after my completion of DM cardiology from CMC Vellore to come over and serve. I thought I wanted to develop the cardiology services at Rayalaseema. I stayed back, so probably I have come to this Vijayawada city and as a Vice Chancellor. So there's a dream that as present Honorable Chief Minister is grounding the capital at Amaravati. So we are also grounding the new university with 30 to 40 acres of land, with a new university with a college and hospital. So definitely under my tenure, the medical education particularly will definitely grow up the continuing education and the standards of the teachers and also the students, and research part also we wanted to improve further. So with these few words, I wish this function as a grand success. I once again congratulate Dr. Ramesh and the seniors who have come on the greatest stalwarts like Prasadara, everybody like Gokule, Gopchand, Manan and everybody, and contributing a lot to this conference. I wish them all good luck. Thank you.
I now request Ramesh Garu and Somnath Garu to felicitate Chandrasekhar Garu.
హలో చెప్పరా, నేను కాలేజీలో ఉన్నాను, ప్రోగ్రామ్ ఉంటే ఏ చూస్తాను. ప్రోగ్రామ్ అయిపో కేజీలో ఉన్నా, ప్రోగ్రామ్ ఉంటే ప్రోగ్రామ్ అన్నాయి అన్నాయి కూర్చొని టైంకి అయిపోతే వస్తాను. నాట్యం ఈరోజు నాట్యం అందరూ ఆడుతున్నారు కదా, నేనే లేను సరే అయిపోతే వస్తుంది.
I request Dr. K.R. Balkrishnan sir to please come forward. I request Dr. Shiv Prasad to join Dr. P. Ramesh Babu sir in felicitating Dr. K.R. Balkrishnan sir.
I now request Dr. D. Prasad Rao garu to please come forward and Jairam Pai sir joining Ramesh garu to felicitate him.
Thank you, sir. Now I request Thank you, sir. Now I request Dr. A. Gopalakrishna Gokhale sir to please come forward. I request Dr. Somnath sir to join Dr. Ramesh Garu sir in felicitation.
I now request Dr. S. Lokesh Ragaru to please come forward and Shiv Prasad sir and Dr. T.R.B. to felicitate.
Request Dr. Shiv Prasad sir to join Dr. Ramesh Babu sir. Thank you, sir. Now I request Dr. G. Thank you, sir. Now I request Dr. G. Balasubramani sir to please come forward. I request Dr. Jairam Pai sir to join Dr. Ramesh Babu sir in felicitation. I request everyone to just stay back
Join
for
for
a
a
group photo.
picture. Join for a picture.
Please join for a group photo.
ಇಲ್ಲ ಮೂಡೇನಿದೆ.
Dr. Bhaskar Naidu sir, please join.
Can we have Krishna Mohan sir also join the photograph, please? Very sorry. As an alumni of Guntur Medical College, I feel so proud. There have been so many legendary people who have been from the same college. Feel really great and happy about this. Thank you all so much.
Thank you one and all. A big round of applause to all the legendary in the cardiac sciences.
stent. So, but not in all the cases. We see, though we keep practicing STEMI daily, but we keep frequently seeing the cases where we won't be able to place a stent. We think twice before placing a stent. It's not because that the placing the stent is difficult, but we think twice because when we place a stent, there can be some sort of serious complications like no flow or reflow, which will be danger to the patient. So, but then we cannot leave the patient as such way because we need to establish a clinical flow there. So then we have some options in our basket which are not thoroughly to the guidelines, but then we use it as a backup strategy like some intracoronary drugs or using thrombosuction or placing any other assisted balloons and all to support the patient. So with this, we actually got few cases from our database in the past 20 years, beginning from the 2005 to almost the case recently we did 1 week back. We just wanted to show you these cases and know your opinion, your approach in dealing with these cases, and later we'll show that how did we approach in this case. Yeah, that's case number 1. So case number 1 was back in 2005. This was a 44 years male with ST elevations in E1 to E4. And EF was 40%, window was 4 hours and angina was there. And case number 2, a 26 years male with ST elevations in extensive anterior MA with low EF with cardiogenic shock and pulmonary edema. And case number 3, so in a 54 years male with inferior MA and 40% EF in 2 hours window period. And case number 4, a 51 years male with ST elevation in A1 to A4 with 35% with severe angina within 4 hours of presentation. And case number 5 is a recent case which we did 4 days back. A 31 years female with ST elevation A1 to A5 1 AVL. So 35% EF, window period 3 hours, was given streptokinase outside, 2 hours, no relief in angina, severe angina, BP 80 systolic. So referred to our hospital.
Here in the first case, like a 45-year elderly male with ST elevation anterior wall MI with ejection fraction 40 moderate LV dysfunction. Because the patient is in window period 4 hours, it looks like straightforward primary angioplasty. We first wire the LED vessel and do ballooning, and we can look for the flow, TIMI flow, and then put a stent in the first case. Second case looks like patient is in shock with hypoperfusion, peripheral hypoperfusion, and SPOT is also 80%. So with poor ejection fraction, and we can see the left main thrombus extending into the LED vessel. In the second case, I will not definitely risk the case by putting a stent. Better to give intracoronary thrombolytic, fibrin-specific thrombolytic agent like tenecteplase. And third case also looks straightforward. We can wire the vessel and try to put a stent, balloon it and see the flow, and then put a stent here. Next case. Here again in the fourth case, it's like osteoproximal LED vessel. It is anterior wall MI with low ejection fraction 35%. Again in this case we don't risk putting a stent because we often see thrombus migration in the osteoproximal LED vessel. If you put a stent, the thrombus might migrate into LCX OM, and we see a lot of catastrophic events here. There will be definitely fall in BP, patient may go into shock suddenly, and we can sometimes lose the patient. Last case also, it looks like there is lot of thrombus burden Here, this is a 39-year female young lady with extensive anterval MI and severe LV dysfunction with low blood pressure. Here also we can try putting a wire, but the vessels look ectatic. Better to go for again intracoronary thrombolytic agent.
What is your order of preference? Like, say in the second case where there is left main thrombus, do you wire and then establish some flow and then give thrombolytic, or you just straight away give thrombolysis?
No, if you want to, if you want to intervene, better to wire the vessel. Otherwise, we don't wire the vessel. We will better to go with thrombolytic agent, give heparin, and direct intracoronary thrombolytic is better, because sometimes even wire manipulation, it can push the thrombus into LCX vessel also. So better not to touch that ostial positions and left main thrombus.
Yeah, but from the regular procedures, we all, as all of us can see, it's grade 4, grade 5 thrombus. So obviously you go for a thrombosection, which is not proved in regular cases, but in these cases, because of high thrombus load, that is an extra. And GP2B inhibitors anyways, that is an option for us.
Yeah. So may I go through the cases, how did we approach in this case? So in the first case, initially there was hardly any flow, we could say, in the distal part of the LED. Small thickening of the flow we can see. So what we did initially was, because there is a huge chunk of thrombus, initially we had put this GP2B/3A drug little. So with that we were able to see little flow into the distal LED. So then we used the export thrombosuction catheter. So after that we waited for some time. Initially after thrombosuction there was the flow was better, but after some 15 to 20 minutes, after a few runs of thrombosuction, we were able to get that underlying lesion, which is moderate lesion. Much of the thrombus have been taken out. So this was the thrombus which was taken out, and we did this CT coronary angiogram 7 years later, so which showed the LAD was patent and almost the lesion was seen. So later, almost like 16 years later, back in 2021, he came again with chest discomfort, unstable picture. So we did angiogram then. So LAD lesion remained same. Almost there is no progression in the LAD lesion. And if you see in the OM, there is a new onset lesion, but patient wanted even medical management on that OM also. So we left him, and then he was doing fine. So in the second case, so he was 26 years old man who almost collapsed in the emergency. He was gasping. So BP was not recordable. He was in pulmonary edema, extensive anterior wall MI. So first thing in our mind was to intubate the patient and take him to the lab and put IABP as a backup. So we did. And then first thing we wide LAD, and then we wide the LCX, because we don't want the thrombus to migrate into the LCX and close the vessel. We want to secure LCX here. But immediately after wiring the LCX, the vessel closed. On the table he collapsed, so we had to do CPR, we had to do all the things, we had to push drugs and all. So immediately we first initially opened the L6 because that is the one which closed and the patient collapsed. So we did POPA to L6 followed by POPA to LAD, and then immediately we put some GP2B/3A drugs, and then we did multiple runs of thrombosuction here. So that was the thrombus isolated, and this is the flow post thrombosuction and post GP2B/3A drug infusion. We didn't give any intracoronary thrombolytic agents here. So this was the flow, and we did a check angiogram after 15 days just prior to his discharge. This was the flow. So in this case, what we did was, so what is really important is to establish a TB3 flow in cases of STEMI. Most of the times, what we do upfront is to balloon it and if possible to stent it. But then we face situations where we know we cannot stent it. We know that stenting is definitely going to be dangerous in these cases, causing serious no flows or reflows. But then we have to have these options as a back up to do sometimes, and we really got a very good flow. But patient was in the hospital for 16 days. He developed CHP. He was on ventilator. We had to put him on TPA. Slowly recovered. When before discharge, this was major. So this was me. So the case number 3, this was RCA. If you see in the angio, there is a huge chunk of thrombus from the proximal to the almost distal RCA till the crux where there is a layering of thrombus. So here the patient was having severe angina on table. So initially we wide, and in this case we did intracoronary thrombolysis and thrombus extraction. Despite doing intracoronary thrombolysis and thrombus extraction, we couldn't clear the thrombus in this case. These are called as like hostile or resistant thrombus, which even doesn't respond to even this backup measures. So as there was no improvement, then we thought like, yes, because the patient was having chest discomfort, then we thought like, let's go ahead and try to put a stent and whether can we patch the thrombus to the wall and we can get some good flow into the coronaries. So we did that. We deployed a 4 into 36 mm stent, and then we took a shot, and most of the thrombus cleared. And 5 days later, this was the angiogram where the thrombus was cleared. And 5 days later, we did the non-culprit vessel LAD, and then he got discharged. So the point is, it is not that all the backup cases of thrombosuction or intracoronary drugs sometimes may not be proving beneficial in removing the thrombus. In such cases, we can take sometimes, we can plan for deploying a stent where sometimes patching the thrombus to the wall can establish a coronary flow, but it may not be safe all the time. Sometimes it can be dangerous, even causing no flows and all. In this case, we took that chance of placing a stent. In case number 4, this was the case where the patient was having severe angina in the emergency. He was a 51 years male. So when we did angio, it was like almost there is a dot osteomyelitis thrombus. That even the placing the wire, pulling here and there, and even taking a balloon would cause thrombus to pull back to LAD or L6 or something. So first initially we took a chance of putting an intracoronary thrombolytic agent into the vessel. So we were waiting for some time, and as you can see in the second run, there is some flow established in the distal LAD, and the ECG changes started to subside on the monitor, and patient started to feel better. Angina subsided. So we thought, let's not enter into this, not even put the wire. We'll just wait and watch because the symptoms are better. So 5 days later, because everything is fine, we did an angio 5 days later, 5 to 6 days later, which showed actually not a significant lesion underlying the thrombus. It was just some sort of plaque which would have ruptured, some mild to moderate lesion. And so he came for follow-up. This case was done back in 2021. Recently he came for follow-up. When he got admitted, his EF was around some 35%, but when he came for follow-up, his EF was almost 60 normal. So there's a case number 6. So this case, the patient was in shock. Patient was thrombolized outside, severe chest discomfort. Post 2 hours of thrombolysis, patient was having severe angina. So initially what we did was, it was a left codominant circulation. What we did was we passed a wire, we tried to open with a bigger balloon because the vessel was big there. So but we couldn't establish any flow there. So then what we did was we took a thrombus to first run. So post thrombus to first run, there was little improvement in the flow. That was the flow. There is little improvement. So but then we took a thrombus to second run. We did multiple runs, and after 2 to 3 runs, we knew that there is little improvement in the flow. And then what we did was we delivered the drug to the distal part of the LAD through the thrombus itself. We gave Micran, ADR, nitroprusside, and all the stuff. Actually, the BP improved. The BP was around some 120 nanotropes, so we took the chance of pushing the drugs. So that was a distal shot taken from the thrombus where we could see good filling of the distal vasculature. So that was the final shot. We know that the tiny flow is too, and then it's not a very good result. But we were able to establish the flow. And the second thing was the patient's angina subsided, and she felt better. So these are the 6 cases. So if you come to the backup procedure of thrombosection, in addition to the stent, in cases where we cannot deploy a stent, so there were trials. Initially, the trial was the TAPAS trial, which showed that thrombosection was beneficial. In fact, it had a mortality benefit at 30 days and 1 year. But it was followed by a huge number with 7,000 days trial. It didn't show any benefit. So with that, a bigger trial was done in 2016. That was total trial with almost greater than 10,000 patients, which showed it didn't show any benefit with respect to mortality, but there was definitely increase in the stroke with the use of thromboster. So with that, so the use of this thromboster was taken out of, the guidelines have given a class 3 recommendation for upfront use of thromboster, but then the same guidelines have given a class 2B recommendation as a bailout procedure for thrombosection in cases where there is a huge thrombus burden and you find it difficult to stent. So I just want to show you that thrombosections have, of late there are mechanical thrombosections, not just manual thrombosections. Upfront where we can see all manual thrombosection like export to Pronto P3, down like these are angiocheck mechanical thrombosection devices which can generate almost 20 to 30 times more pressure than manual thrombosection, like penumbra and angiojet. And this angiojet Spiroflex BG is the one specifically used for SVG grafts, and Distaflex is for distal vessels. So this one case I want to show where this was published in JACC, where there was a huge chunk of thrombus in the LCX, and initially they planned for a balloon, and then they had a manual thrombosection. Post-manual thrombosection, if you see in the third run, the thrombus got migrated into the LM and then into the LAD from LCX, and it has blocked. That was the complication they had with the manual thrombosection. And because they were not able to retrieve the thrombus, they took a mechanical thrombectomy device, angioflex, and they have run the angioflex into the LAD and into the LM LCX. So post that they got a very good flow in both the vessels.
We are short of time.
Yeah. So, so I'll be concluding. There are 3 more cases. Because we are running out of time, I'll give to my colleague Akif. He'll be presenting the other use cases of other devices in STEMI. Yeah.
Meanwhile,
Thank you.
like in the cases where after thrombosection you have less than 50% residual stenosis, do you find any role of imaging in such cases after doing thrombosection, whether to stent or not?
In borderline lesions, we can do imaging. Definitely it will help to know about the lesion morphology, whether there is any underlying ulcerated lesion or is there any fibrotic lesion. Definitely lesion morphology we can know, but if it is like 50 to 60 or borderline lesion in a primary case, primary PCA, definitely we'll go ahead and put a stent than waiting for
So most of them, if the patient is a young person and you know the clinic that doesn't have a lot of comorbidities, I guess then you can wait in those kind of cases, but it's always a patient call at that time of point based on the presentation. We generally try to give around 20,000 to 30,000 units of STK, but that is actually more affordable for most of our scheme cases. Otherwise, there's some different protocol, but actually we go ahead with that one.
So, good afternoon, everybody. Today we'll be discussing 2 more cases, case-based discussion. That stent is not the only solution for it. So first I'll show you the cases, then we'll discuss about the panel will discuss it. So the first case is a 54-year-old female who is a known diabetic since last 10 years. Came with sudden onset of chest pain. ECG was showing inferior wall MI, that is ST elevation MI. And this was the angio which was done. So here we can see that this is areocaudal view which is showing complete occlusion of the OM here. So ostium there is the bifurcation, there is 100% occlusion, and Then what we try to do is, so when we try to open, first we cross the wire. So after crossing the wire, we can see the angio video which is playing.
Yeah, here distal circ looks small vessel compared to that big OM branch which is their major OM. We can leave that vessel, distal circ, because the bifurcation angle looks narrow. In this case, I don't prefer putting a stent here. Distal circ looks small. Or we can put some, if we have any depth balloon, drug balloon, or we can, or else we can leave it with balloon.
Yes, so for this case, similar sir, we thought even same way sir. So after opening, it looks small caliber vessel. So but we just did a depth for it sir, because the vessel looks around 2 to 2.5 around somewhere. So only depth was done. So usually the literature before does not have much data on and like STEMI, the use of depth in STEMI. So now some literature has been coming up on usage of depth in STEMIs as well, with few landmark trials showing a positive results. So we went ahead with the depth, and the final results you can see on the left side.
So like as you have told depth, in cases if after opening to a vessel, if you have significant thrombus there, do you still do depth sir, or do you think of other options?
No, depth is usually recommended if there is a straightforward fibrotic lesion. We should do optimal 1:1 ballooning and then finally do depth. If there is significant thrombus or if there is major dissection with less than more than grade 2 dissection, we have to switch on to stent, putting a stent. So if the lesion is straightforward, then only we prefer keeping it there.
So this is the second patient, who is a 44-year-old male who is a smoker and already underwent PTCA to LAD 2022. He was a drug defaulter, have stopped taking medicine since last 6 months. Again presented with chest pain, window period of 4 hours, and was anterior MI STEMI. So when we did our angio, we found this. So in mid to distal LAD, we can see a stent completely closed, and proximal to that there is 100% occlusion of the left anterior descending. Just wanted to know sir, how you approach to this.
We can wire the vessel and see the flow, and then do routine ballooning and look for TME flow, and then plan about stenting. It's straightforward, looks like primary angioplasty, no?
Yes, similarly, we actually, when we cross the wire, sir, after crossing the wire, we can see in the first image here, the vessel, after crossing the wire only, it's almost opened with some thrombus, which you can see at the junction of the proximal edge of the stent. So we were just wanted to, it was done recently only, we just wanted to avoid putting an overlapping stent to increase that may increase the risk of stent thrombosis, and also we just went with a DEB also for this patient, and the final result came out to be well.
Ultimately, the TME flow is important, and microvascular blush should be there. So these primary totally occluded vessels, we should maximally minimize that microvascular obstruction. That is, if TME flow is good, the result and mortality benefit will be more.
So I'll just wrap up in just 4 or 5 slides here. So the landmark trial which came up was a Revelation randomized trial which compared paclitaxel coated balloon angioplasty versus drug-eluting stents in acute MI patients. So they have taken around 180 patients in half of the patients, 120 patients. In half of the patients they have put a stent, and remaining half they have gone for drug-coated balloons, and only non-severely calcified vessels were only included in this study. So here they included all types of MI, and also the reference vessel diameter was also around 3.28 mean. So this study has showed favorable outcome. Also a meta-analysis was seen comparing DCB versus DRESS, which also showed non-inferiority of DEB when compared to the drug-eluting stents in patients of stents. Thank you, sir.
Sir, nowadays, as a part of our policy for primary BCS, if the patient is young smoker and has huge thrombus burden, we are trying to open up the vessel, see the flow, and wait for a few days, and then take up the patient again and do an imaging as a routine and see if there is erosion or not. Many a times, even though if there is rupture also, if the thrombus burden is low and the area of residual stenosis is less than 50%, we have case series now where we have left the lesions and the patients are faring well. So that's what we are trying to do more and more nowadays. Yeah, thank you to the panelists. Thank you.
Thank you everyone for your valuable inputs. Now
Nicorandil. So the way the thrombus behaves is purely individualized, and we should be able to take on-table decisions because the time which we have is only seconds before the patient gets destabilized. And recently I did one very stable PCA to LAD. Just before removing the wire also, the other vessels are absolutely normal. Just after removing the wire I took one shot. The thrombus migrated from LAD to terminal OM. It's a very tortuous vessel. I tried to wire it. I ballooned with 1 millimeter. I don't want to meddle with that small terminal OM causing perforation, so I'm forced to leave that vessel. So such things happened. Later the patient developed mild MR, went into pulmonary edema, but LV function was absolutely normal. She got discharged after 4 days. So the way the thrombus behaves is very individualized. What do you say regarding this?
Totally accept. So the behavior is erratic at times, but that's what, as I was emphasizing, with more and more use of imaging, and many times if there is no rupture and if there is only erosion, these thrombolytics, intracoronary, all works well. And one major concern which we think of after taking out the patient from the lab is reclosure or the abrupt closure of the vessel. That's what we are concerned of. That's why we put the stent as well. So probably imaging has a greater role here, and that's helping a lot. And obviously clinical characteristics of the patients and the hemodynamics also play a role. That's it. We conclude the session. Thank you.
we request Dr. Anup and Dr. Akif to please present the mementos to the panelists on dais.
టైం కూడా సిగ్నల్ కొట్టుకుంటుంది ఏమి దొరుకుతుంది హ్యాపీనా
Next, we move on to a topic on angiographically intermediate lesions, a common problem but a big enigma.
I request Dr. H.S. Somnath and Dr. V. Senthil Kumar to moderate the session.
And I request the panelists, Dr. Srinivas Chaudhary, consultant cardiologist, Dr. A. Srinivas Kumar, cardiologist, Citizen Hospital, Hyderabad, Dr. K.
So in the morning session as well, Ramesh sir was speaking about it. So we will try to discuss a couple of cases and discuss the problems associated with the intermediate lesions. So we'll speak about the first case, which is a 51-year-old female who's been a hypertensive for the last 9 years under control with a significant family history, presented with possible cardiac chest pain for the last 1 month. There is no dyspnea. She has normal ECG as seen and good LV function. LDL is slightly higher with value of 156. Other blood parameters are normal. So I would like to ask the panelists what would be the appropriate next step in this patient. Mic please, mic to the panelists. So we have a 51-year-old hypertensive with family history and a possible cardiac chest pain. So what would be the next investigation to...
Yeah. Yes, this is a 51-year-old female with a strong family history and having hypertension as a risk factor and symptomatic. So better with an elevated LDL levels, I would suggest to go for an angiography for this patient. To advise an angiography for this patient to know about her coronary status.
So if you look at the ACC or ESC, though not completely validated in our Indian population because we have a higher risk of ASCVD, she would fall into intermediate group, and we went ahead with CT coronary angiogram because it was just a possible cardiac chest pain and did not look like a typical angina. So as you can see, there is a 70 to 80% lesion in the LAD as well as RCA, and there is no obstructive disease in the L6. So what would you do when you have a CT with 70 to 80% lesions in LAD and RCA?
Yeah, this means in such a borderline scenario where the steno severity is borderline between 50 to 69%. So I would ask the radiologist for any high-risk signs or features of the plaque morphology, for example, any low attenuation or any napkin ring sign. So punctate calcification. So this would help us to maintain, to know more about the plaque risk, assess the plaque morphology better.
True, sir. True, sir. So we also did the same, but since we are also having CT FFR now in our hospital in-house, so we also have additional information of CT FFR along with the plaque analysis which you were mentioning. So the LAD lesion showed a CT FFR value of 0.77 and the RCA was just borderline of 0.82. And with respect to the high-risk plaque characteristics which you were saying, posterior remodeling, low attenuation plaque and napkin ring sign in LAD lesion, and positive remodeling and low attenuation in RCA. So these are the features. One is positive and the other is negative. So what would you do now at this point?
Yeah. Can you just go to the previous one?
Yes, sir.
Here, if you see, the calcification is there in the lady, in the proximal and mid segments. This CT angiogram wise, it looks like moderate, and the tightest lesion in this frame is in the junction of the mid and distal LAD. The management mainly depends on where is the lesion, whether it is proximal LAD or mid LAD. Because if it is in the mid to distal LAD, probably you can consider even managing it medically. The patient is not symptomatic. If it is proximal LAD or ostial LAD, you have to be more careful and critical in taking the management decision. And here CT-FFR is there and LAD it is significant. So what's the important here is we have to understand how strong CT-FFR correlates with cath lab FFR. That is the question we
That's
want
what
to
we
know
also
from
wanted
you.
to know, sir. These were the early days when we had the software. So obviously we wanted to confirm these findings. We went ahead with invasive angiogram. So almost similar findings were seen in invasive angiogram as well. And then we have done RFR as well as invasive FFR. RFR was 0.89, again just borderline, and invasive FFR was again 0.82. And also with regard to the plaque analysis also, we have
Again, can you go back to the one frame, the previous slide? Next.
This is the next one, sir.
If you see the angiogram, you can see the tightest lesion in the conventional angiogram after the septal, in between the two diagonals. Angiogram wise, it is the tightest lesion. But all of us should remember that conventional coronary angiogram is only a two-dimensional thing. It is not a three-dimensional thing. So you did OCT, definitely it is useful. And based on this FFR and RFR values, you can manage it medically if the patient is not symptomatic. And the
OCT had the minimal luminal area of 1.77, sir, with the area stenosis of 72%, and it was also a fibry fatty plaque, and you can also see cholesterol crystals at 7 o'clock position as well as 11 o'clock position. So we have vulnerable plaque characteristics on OCT as well as CT coronary angiogram with borderline FFRs and CT-FFR. So again, we brought up this case because it was a real challenging case or a diagnostic dilemma. We don't know, everything was borderline. There are certain high-risk plaque characteristics. Physiology was borderline. We never knew, and I think probably leaving on medical management is also an option. So we had a shared decision making on this, sir. As per ischemia, we can obviously leave the patient on medical management and do aggressive lipid lowering therapy and antiplatelets. We had a shared decision making regarding the same with the patient family, the pros and cons of doing such a thing. And finally, we went ahead with stenting. But the point which we wanted to make from this case is, as sir was mentioning in the morning also, intermediate coronary lesions, even after multiple investigations, also sometimes become a difficult decision to make. And nowadays, the upcoming concept of CAD imaging and triple aim of CTCA, where you know the anatomical stenosis severity, you know the plaque characteristics, the high-risk plaque characteristics, and physiological assessment. All the three combined together would help us, the interventionalists, to make a better decision rather than just simply a CT coronary angiogram or just simply an invasive angiogram, which is absolutely probably not at all helpful in these intermediate lesions. So after everything, though we have stented this case because patients also wanted but the same case on the right side, where similar intermediate lesion was there in the mid-RCA, the CT-FFR was negative, the invasive FFR was also negative, and even the OCT, did not show any high-risk plaque characteristics, nor the area stenosis was also significant. We were able to comfortably leave the RCA and only stent the LAD in this case. So just wanted to show the complexity associated with these intermediate lesions and how the upcoming technology of CTFFR and the plaque characteristics are helping us to make better decisions than the previous years. So I'll move on to the second case. If anything the panelists want to say.
They have more of a mature fibrous plaque.
And also, like as I was saying, these were our initial days. But now, since we have validated these CTFFRs with many invasive FFRs now, probably at this time, after the CT itself and the FFR being negative, we would not have even gone with invasive FFR in this case. So that's what it is helping us. Probably we are trying to learn more and more from these cases.
Managing these patients on high dose of statins to passivate the plaque could also be one option. Suppose, as you have explained to the patient.
Optimal medical therapy would definitely play a role, whether you stent it or not stent it.
Yes.
Yes, sir.
Can you please play RCA OCT again? Angiographically, the lesion looks long lesion with conventional angiogram also it looks like significant, but FFR is negative. So you have to believe FFR when you do FFR. The lesion is long. If you see the OCT, here also the lipid burden in the plaque is big. And if you want to have a holistic approach in such cases, you have to bring down the lipids at a faster rate. You have to consider injectable lipid lowering drugs in such scenarios.
Even this patient was having LDL of 156. We have kept the patient on statin as well as histamine. The latest follow-up value of this patient was less than 55. It was actually 45. So we were comfortable. Otherwise, we are also giving PCSK9 inhibitors in such population as well.
But again, to conclude, the clinician is the best judge. He has to take all the things into consideration and take a meaningful decision.
The points are well taken. Only thing is now the LAD. Your OCT shows 1.7
in LAD
by any LAD. Yes. So any standards, so it is significant. And the other thing is it's a very long lesion, and atherosclerotic burden seems to be high. Number 3, the proximal LAD calcification extending into the left main also. So all these factors put the patient on high risk, and the more important, like your OCT, if it were to be something like around 3.5, probably very aggressive lipid lowering and all. But leaving this in an active patient without doing anything, we were not very sure. But still, we gave the shared patient decision, and that's how he went for a PCI.
It's the right approach.
I'll be quick with my other cases. I think we are short of time. So the second case is a 62-year-old female diabetic with chest pain with diaphoresis since 3 days. ECG echo were normal, blood investigations were normal. LDL was 49. She was on statin previously. She was using for diabetes. One physician has written it. So now she presented with chest pain with diaphoresis since 3 days, and troponin was negative. So what would be your approach now again?
This patient had done maybe an angina, means typical angina over 3 days period, the drop negative and unstable angina. In this patient, suppose if you do have an CT modality, that I would suggest him the CT. That would be my first option, I think.
Yes. So as per our hospital protocols as well, we are
In such scenario, the most important thing is you have to repeat the troponin after 2 hours.
Serial troponins are negative.
If serial troponin is also negative or same, then with chest pain and diaphoresis, you have to think of non-coronary options also. Sometimes it may be an aortic dissection or a pulmonary thromboembolism. So every chest pain with diaphoresis need not be coronary artery.
Yes, considering that other causes are ruled out, so it considered as coronary only. So as per our hospital policy, we went ahead with CT coronary angiogram. So you can see with the calcium score of 235, we have an intermediate lesion again in LAD, proximal to mid. L6 lesion was tight. And the CT-FFR value for this LAD was 0.72. And with plaque characteristics of positive remodeling and low attenuation plaque. So what do you think should be the next thing? How would you approach this?
In this, we are getting out of the four signs of the VP, vulnerable plaque, out of the four, two came positive. It's a low attenuation plaque and positive remodeling. So I would suggest to go for a conventional angiogram in this patient.
So the conventional angiogram, as you can see, the short left main with the LAD in cranial view, you can see there is a hazy looking lesion in the proximal to mid LAD. And we have also, by this time we were slightly convinced with the CT-FFRs, and we have validated also. So we did OCT just to see what the hazy looking lesion is, whether it is some other plaque rupture or something, or just calcium which is looking like that. So we have an MLA of 1.56 in a vessel which is almost 2.75, and OM1, OM2 were significant, as you can see, and also distal LCX, though it's not clearly filling in the cranial view, the distal LCX was also significant. So with the information, since LAD was significant and two branches of OM as well as LCX significant, we actually had the information of intermediate lesion, which was confirmed on CT-FFR that it is positive, and with high-risk plaque characteristics and a fibroflatty plaque on OCT. We have gone ahead actually with CAVG, since he was also a diabetic also, with the major vessels involved, and he was given grafts to LAD and the patient is doing good. So similar case, third case, again we wanted to show cases where initially we have validated, and then we now have all the information with the CT itself, and our invasive assessment was almost similar to what we are seeing on CT, and this is helping us a lot. Even before taking the patient to cath lab, we know all the information and how the lesion is, what the plaque characteristics are, and what the physiology is. So this is the controlled LDL. This patient on assessment actually showed a significant disease in LAD, but the LCX osteoproximal was 50 to 60%. I'll show you the angiogram as well. So it is around 50 to 60% osteoproximal LCX. RCA was not a big vessel, but if you can see the CT-FFR, the value was 0.80. So we were not sure because angiographically it would look like 50-60% lesion only. We also did the OCT. So the vessel, as you can see, is easily 3.5 vessel, and the MLA of this lesion actually was 2.6 millimeters square. For a 3.5 vessel, it would give a area stenosis of 76%. Also, this patient had some thrombus seen in the osteoproximal L6 as well. So with all the information, sometimes though we are conventional thinking of 50% lesion might not be significant, but the CT-FFR actually showed a value of 0.8, and that has been confirmed on OCT as well. So we have encountered such cases where many of the conventional thinking of ours have changed after looking into all the characteristics, and also CT-FFR is helping us a lot. So we just wanted to show these cases, how these cases have helped us a lot. And I'll not go in much into the literature.
Nobody would expect a thrombus in LCX looking at this angio.
Yeah.
And so surprises are also seen hazy. So surprises are also seen sometimes with this when you're looking at combination of things. Both the FFR and imaging nowadays, though you have to be selective, but in proximal vessels, we should not think twice before ruling out anything, because patient can land up with LCX complete occlusion. There could be some erosion or rupture, which is responsible for the thrombus, and she may land up with inferior MI. So this has helped us. So that means still the cost, everything, how do you balance it is the most difficult thing. Now we are finding, we know most of the things. Most of the things we know that 20% chance that there is a problem. The problem is with the patient's trust and then money.
So CD. Sir, again, sir, LCX was significant, OCT wise. LAD was significant. It's a large LCX. So we have done CAVG.
Okay.
Yeah. Non-dominant RCS. So we wanted to emphasize that CT is now becoming a one-stop solution or one-stop shop for all. And with more and more learning, we have understood that the value of CTFFR, just a single number is not what is important, but you should take the things into totality. Like what is the vessel territory? Is it an LAD or a non-LAD? Is it a proximal vessel, as you were saying, mid or distal vessel? And sometimes delta FFR, the drop of FFR value across the lesion also sometimes matter, and studies have come up saying that 0.12 is what is considered significant. And the plaque burden which we get and the high-risk plaque characteristics on CT are helping us a lot. And so the strength... Yes, slope of the drop. Yeah, I think not included, sir. Show the stop. Yeah. Just like the invasive FFR, the delta FFR, the sudden drop in the FFR value on the slope helps us saying that there is risk. Obviously, you give a nose and you put a wire, and those associated risks are negated. And CTFFR in studies has shown to have a very good negative predictive value. That's what we wanted in these intermediate lesions, and it has a good negative predictive value. And CTFFR, as I was mentioning, is not a continuous variable. It indicates a continuum of risk, and you take other factors into consideration and then decide on your plan. And ACC/AHA in the 2021 guidelines has given a class 2A recommendation for use of CTFFR in an angiographically intermediate lesion. One major thing which has been there till now is high cost associated with CTFFR, because heart flow costs a lot and it's not feasible for in our setups to do. But now with the upcoming CTFFR, which is on site and which doesn't add any cost to the CTFFR, so the thing of cost is gone now. And the second thing, requirement of high quality imaging with the old CT scanners which are less than 64 detector is the problem thing, but now almost all the major centers have CTs which are more than 64 row. So that also doesn't become a major problem, and probably this is the time where we can safely say that CT is now going to be the one-stop shop. So I would like to conclude this intermediate coronary lesion session saying that they are commonly encountered, they are ambiguous in angiography, making the clinical decision very challenging. Anatomy alone is definitely not enough. Physiological assessment definitely helps in knowing the lesion significance. CTFFR, the physiological assessment with CT, helps in to getting more insight about the CT angiogram lesion severity. And we have shown real-world use case of CTFFR, and this helped us in solving the ambiguity, and it helped optimizing the patient care. And tailored approach combining all the CCTA features help us in making. Finally, the problem with intermediate coronary lesions is we are always in dilemma, and we cannot confidently tell a decision. Probably that decision making is what CT is helping us. And as I was telling previously, triple aim of CCTA, that is anatomical severity assessment, high risk plaque characteristics, and physiology are going to stay, and they are going to be the future. Thank you.
Manohar, good presentation.
Thank you, Dr. Manohar. And I invite the next speaker, S. Venkatesh Reddy, cardiologist, Aster Ramesh, Vijayawada.
I think those cases are also covered, Dr. Venkatesh's cases are also covered here. We can go to the next session.
Now I request panelists to stay back, and I request Dr. Somnath sir, Dr. Sabadi sir, and Dr. Ramasubramaniam sir to come on to the dais to give away mementos to panelists.
For our next session, now I invite Dr. G. Krishnamohan sir to come on to the dais and moderate the session. I request Dr. Sriman Narayana sir to come and join on the dais as a panelist.
We request Dr. Subramaniam sir, Senior Consultant Radiologist, Ramesh Hospital, to join the panelist.
భయ్యా అయిపోయిందా సరే ప్రింటింగ్ పంపిస్తున్నానని చెప్పి.
Now I invite Dr. V. Vivek Reddy sir, Consultant Cardiologist, Aster Ramesh Hospitals, Guntur, to come on to the dais and present the topic.
Namaskaram everyone, I'm Dr. Vivek, I'm Consultant Cardiologist at Aster Ramesh Guntur. So today we're going to talk about the last topic was intermediate lesions, right? So we're today going to talk about patients who do not have intermediate lesions but have no symptoms before coming to the hospital. So we call that the silent threat. And we are going to try and understand and manage subclinical coronary atherosclerosis, the hot topic about discussion. So here we have case 1 is a 70-year-old male doctor from Karnataka, not a known diabetic or hypertensive, a known case of hypothyroidism, came for a naturopathy treatment and was asymptomatic until he was brought to the emergency room with history of chest pain associated with palpitations and profuse sweating on 16th of April 2022 at afternoon while swimming for about 30 minutes. His lipid profile was relatively normal. This was his ECG on presentation. It was consist of acute anterior MI with QRBB. The consultant there has seen and advised an emergency angiogram and a primary PCI. This was the angiogram after taking to the lab. You can see a proximal occlusion of the LAD. Looks like an acute thrombotic occlusion. So a primary PCI was done to the LAD to save the patient at that point of time. You can also see a significant lesion in the proximal LCX, about 80 to 90%. So this was the result with TIMI-3 flow. A primary PCI was done with TIMI-3 flow, and he also underwent a staged PTCA with the stent to LCX in the same index admission because he also had a possibility of travel to Karnataka. This was the ECG post-PCI. Patient is doing well after this. And here we have case 2. Is a 57-year-old male patient, not a known diabetic, hypertensive. There is no family history of CAD. He also plays 4 games of shuttle daily, was asymptomatic till presentation, and has a BM of less than 24. So he has absolutely no risk factors when it comes to CAD. And he presented with chest pain with sweating for 3 hours. ECG showed anterior wall MI and echo showed moderate LV dysfunction. And this was the angiogram on presentation. You can see an osteoproximal occlusion of the LAD, a significant lesion in the LCX and ramus, and a significant lesion in the RCA with collaterals to the LCX. So, an IABP was put for hemodynamic support, and the patient was sent for early CABG. He was doing fine after that. Now I invite my colleague, Dr. Sivakrishna, to discuss the next few cases.
Doctor, the aim of this presentation is to show that patient could have severe disease without symptoms. That's what you're trying to highlight?
Yes, sir.
Even without risk factors?
Yes, sir. completely asymptomatic till presentation, but on presentation has severe disease.
You should not terrify people also. The occasional exceptions will be there, but everybody is not having symptoms. May not have always this thing. Extremes are there, definitely.
Yes, sir.
But it is more likely to be positive in patients who have higher, definitely more risk factors. But the other way is not true. That's what you are wanting to show.
Yes.
Huh? As far as we can say, I think, in that.
I'm glad you clarified that, sir.
Okay. You can go for.
Good afternoon. Coming to my next case. A 58 years male patient. He was absolutely normal before coming to the hospital. Has a cough since 1 day and shortness of breath, NYHFL. He was in pulmonary edema in ear and there was no comorbidities. Patient was intubated in view of tachypnea and desaturation. And this was the ECG showing sinus tachycardia with multiple VPCs. And there was also non-sustained VT runs also there in monitor. So patient was taken for the angiogram. So you can see there is a extensive triple vessel disease. He was LAD, osteoproximal cutoff, and LCX. There is a significant disease with coronary aneurysm, and there is also, you can see, the retrograde filling of left system from right coronaries. And patient was put on IABP for the hemodynamic support, and he was put on medical management in view of extremely diseased coronaries. He was approximated survival time of less than 1 year. However, he came for the follow-up. At the time of presentation, his ejection fraction was around 25, but after 9 months, the ejection fraction was around 40.
You did something or God did something?
No, only on medical management. Dual antiplatelets, statins.
God saved him. Huh? God saved him.
He was on invasive ventilation for 48 hours and also on IABP for 5 days. So there was a gradual improvement and clearance of the pulmonary edema. Pressures also were a little low earlier. Slowly they picked up. So we feel that looking at this, there is no way you can do CVG or PCI, but probably that is the time you give for sometimes collaterals to open up also. We have few more patients like this, where it is difficult to wean the patients in the initial 24-48 hours, but on extended IABP support, we have seen them recovering and then successfully we could wean off. This is one patient. Anyhow, you complete the other cases. Now the issue is, one, how do you manage? Number two, the more important is, what is the screening methodology which we are following, and are we following the global risk scores, or in India, do you have to propose a different mode of CAD screening, and what is the evidence to say if you are trying to say something different from the current guidelines in asymptomatic patients? Okay, complete the other case also. Let the chair.
Coming to the next case, a 39-year male patient came with chest pain and sweating for 4 hours, and ECG was taken. It was extensive anterolateral MI, and there was recurrent VT runs with multiple times. DC cardio shock was given, and echo showed moderate LV dysfunction, and he was put on CAG was done. There is a extensive LMCA disease plus triple vessel disease. Patient was put on IABP, and primary PTCA with shunt to LM to LAD was done. So the first sign show this is there is a diseased PDA, and you can see there is a significant LM disease, and there is also proximal LAD disease, and patient was taken for the primary PTCA from LM to LAD, and patient was put on IABP, and this was the final result. And ejection fraction was moderate reduction, around 38 to 40. And after the procedure, before the procedure, there was a moderate mitral regurgitation. After that is a mild mitral regurgitation. I would like to invite to present next 2 cases, Dr. Ramarao Garu, Senior Consultant Cardiologist, Ramesh Hospital, Guntur.
You want discussion happening after the presentation of all cases? Okay.
So, good afternoon, everybody. So, this is the patient of 41 years male, So he came with complaints of just SOB from last 3 months, and he came for routine health checkup. So he underwent CTCAG, and he denies any history of chest pain. So CTCAG is showing almost near total occlusion of LAD. So he underwent angiogram, then followed by PTCA to LAD. So he was fine. So other patient is 76 years male with history of diabetes and hypertension. He came for routine health checkup, and is on routine evaluation. His calcium score was 1143, and because calcium score was very high, we did angiogram, LMCA plus DVD, and he underwent for CABG. And this is the interesting case. So 35 years male, he is a software employee from Hyderabad, and sedentary lifestyle, and he came with chest pain from last 3 years. So actually he is feeling that pain is gastric pain. So initially he took Inu and all these things. So pain still not subsided, so he came to ER. So when he presented to the ER, he had shock and collapse. So echo immediately we have seen, and his echo revealed severe LV dysfunction. So this is the ECG. It is showing mild elevation in lead 1 and AVL with ventricular bigamy. Thinking is a ACS. So he was intubated in the ER and cardioverted. So immediately we took for angiogram. So LMCA was total 100% occluded, and RCA was completely normal. So he was. So both LAD and LCX were wide, and thrombosection was done. Despite of that, a lot of thrombus was there. So intracoronary thrombolysis was done. So afterwards, IABP was inserted. But despite of all this treatment, still he used to have recurrent VTVF, shock, oliguria, ventilator support. So he is not coming out, and he is sinking. So immediately within 4 to 5 hours, so we have initiated ECMO. So within 5 days, we are able to remove the ECMO, and by 25th day, we have discharged him, sir. So this is the angiogram after 3 months. So here the main thing is, so we are not talking about the management. So here the people are presenting, most of them are asymptomatic with 1 or more risk factors, but they are having the significant problem. So how to screen this kind of patients? So now the discussion is open to the panel members.
One is 35-year-old,
yes,
39, 41, 56, and 64 doctor.
Yes,
Everyone was absolutely asymptomatic, and they were playing shuttle 4 games 1 day prior, climbed 4 flights of stairs. Likewise, everybody was asymptomatic, not with much risk factors. So that is the crux of the issue.
Yes.
Now in India, so looking at this, all of you must have been seeing such patients regularly. We've been seeing for years together. We get perplexed and we say, oh, unfortunate or something. Then is it really unfortunate? Or is there a way what the routine screening methods what we are following in India at different places? Are they correct? Are we missing? Or now should we change our approach for CAD screening to pick up the right patient in the right time? That is the purpose of this presentation.
Yes, sir.
But many of the patients who are so-called asymptomatic, like that breathlessness patient who had pulmonary edema, asymptomatic in the quote-unquote, sometimes he may not have taken evaluation, may not have noticed symptoms. Many of them underplay symptoms. That also we should be careful. But having said that, some patients who are active, playing tennis and all that, that is a real problem. That is, in other words to say, he was testing himself. But most of them won't undergo any sort of testings. What they say is they are very healthy. They don't even get their blood pressure checked, sugar checked, and the cholesterol checked. But once first time when they present, also levels come very high. That also we see. But some about 10% of the patients, in spite of checking without risk factors, they could land in trouble like this, where some other things like genetic history or whatever is reason, they could be playing a role. But by and large, with exception, generally guidelines won't come taking the case examples of exceptions. Guidelines will always think of risk-benefit analysis, how much is the positive predictive value, all that. But for an individual patient who can afford, he should go outright. There is no doubt in it. Suppose, especially when they have a family history positive, then right from very early age, to the extent of, I think you are promoting a lot of CT angio role you are trying to highlight. That is well taken. For a patient who can afford anything, that is his right to get it done. But for a general population to suggest in screening, that's where we fail, because the cost versus benefit, the pickup rates, that's where we can't get generalized coming to the guideline. But by and large, what you've shown, many of us have seen, all of us have seen cases like this. But it's unfortunate, but you did a fairly good job by saving many of those patients. Fantastic work by doing left main PCIs and putting on ECMO. Life is very, should be taken seriously like that. In our country, people who ignore it. But you did a wonderful job by putting ECMO, and then patients are saved. Some fortunate patients are saved by God only like that. But generally, I think if that patient comes out after the ventilator, what is the approach we follow generally is, after the patient is stabilized a little, and probably you also must have thought, these patients won't come only for follow. They will come suddenly after 6 months, 9 months, you might have seen. But otherwise, what we would have done in such patients is probably after stabilization, either pre-discharge or 2 weeks later or a month later, you do repeat angio. Then most of the vessels, collaterals, formation, thrombus would have gone. Then you would have become candidate for revascularization, either CABG or PIT-CA. Some of the patients we saved like that. Even 9 months later, when he came, LV function improved. But if you do an angiogram now, we could have revascularized vessels. There are some unpredictability, but that's where we balance things and try to do it.
Asymptomatic, 60-year-old person to you, and what is your methodology of a screening? Number one, based on the context of the Miami Heart Trial and the Scapis Heart Registry, where the incidence between the ages of 45 to 64 absolutely asymptomatic patients, they have shown more than 40% silent blocks, number one. Number two, in the AIQCT, recent publication, 90% of them had some block. Now in India, where the risk is 2.5 times higher compared to these Westerners, where your risk stratification doesn't apply. There is a study in Apollo, CT coronary angio in Apollo, Chennai, for more than, if you remember, 40-year-old people, more than that, more than 40 years, they have found 40% of them had some plaques. Finding a plaque and finding even one calcium score or 2 calcium score is completely different from 0 plaque, 0 calcium. That means these people are not prone. These are prone, you have picked up at age of 30, 35, 40, whatever. So in which case, as you rightly mentioned, it is not possible to put under the CT scan every patient for CT coronary angiogram. Then how do you pick up? We have certain thoughts we keep discussing regularly when we see such patients. So how to go about? So what are your thoughts on that? How do you screen, let us say 60-year-old asymptomatic person with one risk factor, absolutely like tennis and all these things, one risk factor. So what do the data say and what do you do?
Okay, generally, we are trying to, for foundation, we are trying to collect data, we call it as doctor's health study. We are putting CT scans and doing. Doctors are also poor patients. They don't take statins also if required, including me. We don't like to take tablets regularly. So nowadays some long-acting injections have come, all that is different discussion. But what I want to say is, in such things, you assume that he is anyway positive and give the benefit of treatment to him. Or if he is able to afford it, you want to document it, you can document it by a CT scan. But if you are very suspicious and you have a high positive history, and patient attitude is also important. He wants to go all the way, type A personality, want to protect himself, give him statin dose. If a patient, how I decide is if patient has very high dose, lipids are also a little abnormal, then we give high dose, otherwise at least regular smaller dose statin, and along with aggressive lifestyle modification, whatever is required to prevent, whatever yoga, meditation, active lifestyle, dietary advice, all that we follow. In spite of it, if he lands in trouble, that's a different story. But you consider it as if he's plaque positive. That's what is the approach I take. if he is not able to get a CT scan done. But if he is affording, he wants to get it done, they do a scan. If at least he sees a plaque, he'll be more regular with his medications. Otherwise, he will be negligent again. He won't take whatever you advise. If you document it, the plaque is there in the left main or LED proximal, they'll be more positive and take statin regularly. And nowadays, I'm going to the extent of giving high dose, even injectables like inclisiran if a patient has proximal disease or left main plaques. I think there's no data for prevention yet, but Victorian primary prevention trial is coming, which might show positivity in that. So if there is a documented plaque, you should go out of the way to prevent the occurrence of events in this patient. That's the approach I take.
A 30-year-old Indian patient with either history of hypertension or one risk factor, let us say smoker or family history. So what is the approach, Chaudhary?
So starting from, we should not forget the basics: ECG, echocardiography, and treadmill stress test. These are important. Most often, what happens in majority of the patients, as discussed by the speakers, patients they self-limit when they are doing exercise, they limit themselves, or they underreport their symptoms. So even sometimes if stress test, take standard treadmill test, if it is negative means treadmill statistics, whatever diagnostic criteria, if you apply, still it is negative. If he has strong risk factors like diabetes or hypertension or family history of CAD or smoking or any dyslipidemia, if the patient can afford, my approach is I will send the patient for CT angiography. CT calcium score itself may not be sufficient because soft plaques won't be picked up in CT calcium score. CT angiogram is a better test if the patient can afford, but the cardiologist should spend time on explaining the importance of getting a CT angiogram in many of such scenarios.
Yeah, you rightly mentioned some area, Dr. Chaudhary. The basic purpose of this session is how do you screen asymptomatic patients in Indian scenario? One, we have seen that traditional risk stratification like Framingham or PCA, whatever, doesn't apply to India. Because 2.5 times since already they are in the borderline or moderate risk, whatever. And if they have one risk, that becomes a intermediate and high risk. So here, then next coming to the ischemia stress testing. This is the traditional way all of us have been doing for decades together. Now, even from 2013, 2015, there are lots of articles, studies, registry data, NCDR data, National Cardiovascular Disease Registry, more than 5 lakh patients. They have seen that the ischemia stress testing is not useful at all, number one, because of the poor positive predictive value. And then the patients who are sent with the ischemia stress test, let it be exercise treadmill or stress dobutamine echo or stress MRI or stress spectra. Everything they have done, they have shown that less than 50% of them have any significant disease. That means significant of them are false positive. That is the reason why your 2021 guidelines say that ischemia stress test is not the screening test of choice which you should think. It is useful only when you find 50 to 70% are borderline lesions by the CTCA. That is the reason why class 1 indication, any person, what we follow is like more than 30 years in India, one risk factor. We straight go away, as he mentioned that, you were mentioning that zero calcium doesn't really help. We go directly for CT coronary angio. And many times we don't find anything, but 10 to 20% of the times we find predominantly in the osteoproximal LAD, we have seen many times, and then 20-30%. Then, or if it is 60%, then the stress test comes in the individual. All these come when there is a plaque, significant plaque. Otherwise, you try because one patient, 150, 130, just to they're hyper responders. With rosuvastatin, it came down below 50. So, right kind of drug, right dose based on the presence of plaque. Because even risk factors, 1, 2, 3 risk factors also present. Some of them do not have absolutely any calcium. This we have seen, repeatedly we have been burning our hands, head, and then in 1996, 2000, we used to take the patients, and 3 risk factors we used to get surprised. What is this? Now we know more. We don't do that anymore, and straight away, if one risk factor is there, we straight away go for a CT coronary angio, and if calcium score is there, even 1 is dangerous. Even 1 calcium score is compared to 0 is dangerous. That means he has a predilection for the LDL cholesterol to penetrate through the crevices and then endothelial deposition. So this is entirely a different ball game when you find it. So risk stratification and CAD screening in India is absolutely, now even in the West, now the guidelines have changed. Nobody does ischemia stress test as the first line screening test. In fact, NICE guidelines in 2015 itself stopped depth of stress test. That is what, some of the articles have come. So stress test is, and even many Indian Heart Journal articles you see, treadmill should not be a primary screening test. So that is only secondary when borderline lesions are there, or when, for example, you have seen OCT, and all these things are borderline, patient symptoms to collaborate, to correlate symptoms, so that way the stress test. Otherwise, stress myocardial PET, as Dr. Krishnaraj was mentioning, this is another area, and then even without PET, myocardial perfusion imaging. So one stop shop when you are talking about, so CT, CTFFR, myocardial perfusion imaging without doing can guide you to the cath lab with the proper thought process.
There are certain data showing that ACS occurs in previously documented in mild stenosis patients itself. And some of the studies are saying that treadmill test should not be the part of your routine health checkup. And stress testing cannot detect the vulnerable patient without obstructive CAD, and we will overutilize the stress test. And ischemia testing fails to diagnose CAD. And the problem with the risk scores are they are heavily influenced by the age, and they will over-evaluate in the age of more than 60 and under-evaluate if the patient is age is less than 30, and they are not for the Indian patients actually. And this is the study showing that most of the MIs are occurring in patients with less than 50% stenosis of coronary artery disease. So it is vulnerability of the plaque is most important rather than the obstructive disease of the CAD is most important, and CT-CAG is the most important step for the investigation of screening in CAD. And some of the studies are saying that subclinical atherosclerosis is common in general population even with the zero coronary calcium. So what we do in our hospital is, in asymptomatic individuals with age more than 30 years with 1 risk factors, will go for CT-CAG. So, but coronary calcium itself is not sufficient. Stress testing is neither efficient nor sufficient. Non-obstructive plus, if we see any non-obstructive plaque seen in CT-CAG, then we will start early initiation of statin therapy. That will cause relative risk reduction of atherosclerosis events. Thank you.
Sir, Dr. Ramesh sir, see, basically all these days from our MBBS days, all of us know 30% of the heart attacks can occur suddenly. And even now that is true. And the crux of the problem is how to identify these set of the patients prior to that they develop a acute coronary event. See, basically we know there are various scoring systems. Americans, they have various scoring systems. And by that, every individual we should assess whether there is a good probability of CAD, intermediate probability of the CAD, high probability of CAD. Why they have developed such a system? Because that is cost effective, and it can be used for the mass screening of the community. So by intermediate probability, you do either stress testing or CT angio. High probability, again you go for CT angio, and low probability you have to go for lifestyle modification depending on the scoring system. Maybe what you are insisting on is because of the rampant CAD in Indians, we need to have separate scoring system where we can identify the subset of the patients.
Yeah.
So, your question is whether we should take this risk stratification scoring system before considering CAD screening in Indian patients. So, let us go to the ACC or European guidelines or NICE guidelines. What are the indications for ischemia stress test? Number one, in stable angina pectoris. What is it?
Stable angina pectoris. Stable angina pectoris medical management.
No, till what stage?
See, if the patient is having symptoms on medical management, you should go for
what?
Angiogram, or CT angiogram or invasive angiogram.
No, there is no question of R, either CT or invasive. So, in this, it is only the CT unless for any stable angina pectoris, CT coronary angiogram is the first investigation. Likewise, probable cardiac CT coronary angiogram, post CABG, post PCI, angina CT coronary angiogram, only in acute coronary syndrome. Even in acute coronary syndrome, non-STEMI patients with elevated troponin, even again it is CT coronary angiogram because 50% of the patients do not have any significant obstructive disease, number one. Number two, even if you are taking your patients for invasive coronary angiogram, you are never doing your invasive FFR. Your borderline lesions of 50, 70, 80% by your eyeballing, you are choosing whether to stent or not. That is exactly the crux of the problem, that is the confusion. You say stent, I don't say stent, and somebody else says bypass something. This is the issue. Now, if you have objective evidence of FFR, number one. Number two, corroborated by atherosclerotic plaque burden. Number three, morphologically high risk plaque. Then you can have more objective way of deciding the right therapeutic decision, avoiding confusion amongst the cardiologists. So, in our Indian patients, I don't do ischemia stress test. 30 years plus one risk factor. I go directly for CT angio. Supposing you are not keen, lady, 30-year-old lady, 35-year-old lady, you don't want contrast, you don't want more radiation, then there is something like calcium score stress testing. You do a calcium score, 35-40-year-old, if it is negative, then do the stress testing. At least it is slightly better than not doing or thinking only on or relying only on stress test. This is the other way, like calcium score stress testing is another subset where we advise. Or when there is, of course, the borderline lesions, we do the stress testing to correlate with the symptoms. So now, in Indian patients, yes, guidelines, you are saying guidelines, calcium score was 1990. How long it took calcium score to be accepted? Calcium score, people have discussed that it is a risk factor, whereas it is a disease. People, a lot of editorials, it took 30 years. And then CT coronary angiogram, your 15-year warranty test, when was it published in NEJM? 2015. How many years it took for all the organizations to accept it as class 1 indication and push ischemia stress test down below. Even ACC guidelines, more than 65 are high risk patients, you do ischemia stress testing, then take up for invasive angio, not CTCA. That is the guideline, current guideline, which I am sure will be changed because many patients we see such risk factors having normal coronaries, and treadmill test again is borderline, and then it is more, false positive, false negative, and inappropriate stress testing. Even now in US, more than 50%. That way they have stopped, the reimbursing the ischemia stress test, and even the appropriateness. Even in India now, the Ayushman Bharat people, they are seeing your angiogram, right? We are not doing probably Arogyasri patients. Whoever is doing, they are seeing your angiogram and they are trying to figure out if there is inappropriate PCI done. So they think that even if you cut down the PCI to some extent, significant saving for the system will be there, for the center will be there. They are doing this with the Arogyasri patients also. So appropriateness, once it has come into the picture in 2010, between 2015, the invasive, the PCI rate has come down by 50%, even in US, if you see that. Even now, it is inappropriate in 14%, and uncertain
about 32%, and so almost 50% of the PCI done in the US is still doubtful whether this is to be done or not, because there are several ways and they go by the other cardio.
So combining stress test, that is treadmill test, and CT calcium score is a very good approach that usually I follow in my practice. We can call it as a poor man's choice. If we can't afford CT angiogram directly, they can go for this test. That's one. And the second thing, in a patient with chronic stable angina, sometimes if the CT calcium score or CT coronary angiogram has high calcium burden, the lesion interpretation is not that easy. So first, in such patients, what I will do, I will ask for a CT calcium score. If the CT calcium score is high, or more than say 400, I will go for conventional angiogram rather than CT angiogram. If the calcium score is low, as you said, CT or coronary angiogram can be considered. And the most important point you have raised is, even in normal conventional coronary angiograms, cardiologists, they don't do FFR, invasive FFR quite often. Because if you want to follow the guidelines, we have to follow, do FFR from the lesions ranging from 30% to 80%. But in clinical practice, most often we are not doing that. So CT FFR is really a good way to tackle this issue.
Yeah, you have raised a very important issue, Chaudhary. This is calcium, dense calcification, 400, 800, 1000. We also had a similar discussion, and then we have reviewed the literature. And then what we did, we have done invasive angiogram, almost 450 patients, invasive FFR or IFR, almost 6-7 years ago in between these. And then what we have done, CTCA patients who underwent this invasive FFR, we took back this CTCA patients and then did retrospectively CT FFR. Once the correlation is very good, we started believing our CT FFR. That's why we remained quite, even after announcing, you must have seen that for 3 months we did not say anything about CT FFR. Now only we started coming out, yes, it is reliable, number one. Number two, your dense calcium, your GE, Siemens Healthineers and all others, heart flow, calcium score has no impact, and that is the other important reason for you to go for CT-FFR rather than believing only on cardiac CT because of the blooming artifact, falsely high lesion. So CT-FFR is not affected, and in our cases also, it is not affected by the presence of the calcium. This is the other important reason for you to go for CT-FFR, especially when calcium score is 400, 1000, 2000. It is not affected.
Every patient without increasing the charges, you're doing CT-FFR now. I'm asking.
CT, once you do cardiac
the plot
CT,
is demonstrated, obviously.
Between 40 to 80, then we charge around 10,000 rupees. Even if 10,000 rupees is heavy, in which case patient is absolutely asymptomatic, even 40 to 70%. In such a case, if patient can't afford, maybe a simple exercise ECG just to correlate.
No, sir, I'm asking previously Art Flow used to charge heavily once you want to send them.
Yes.
Now you are doing it yourself here.
Yes, we are doing here. 50 to 70. We selectively choose between 50 to 70. If the clinical picture also suits and patient can afford another 10,000 rupees, we are doing it.
Achha, extra 10,000 only you charge for FFR?
Yes, as of now.
Okay.
Sir, here I want to highlight 2 important points. Even the conventional coronary invasive FFR quite often throws many surprises. The lesions which were significant by angiogram alone, the FFR will be quite contrast, and the other way also true. And another important point is calcium score, high calcium score need not be always a very dangerous thing. We have seen many patients with very high calcium scores like 1000, 2000 with no significant focal coronary lesions which can be managed medically. So just calcium score, in high calcium score, you need not panic. Definitely that should be further evaluated, but is not a point to panic.
Okay, we'll go proceed to the other presentation.
Thank you everyone for your valuable insights and engaging discussions on the case scenarios. Now I request Dr. Ramarao sir, Dr. Vivek Reddy and Dr. Sivakrishna to present mementos to the panelists on the dais.
Let us move on to the next session. I request Dr. G. Krishnamohan sir and H.S. Somnath sir to be on dais and continue as moderators for the next session.
So now I call upon panelists onto the stage. Dr. A. Srinivas Kumar garu, Dr. Sheikh Maulani garu, cardiologist from Guntur, Dr. P.V. N.M. Kumar garu, Dr. A. Shivaprasad garu, cardiologist from Guntur, Dr. P. Paray Chaudhary garu, cardiologist from Guntur, Dr. K. Kamalakar garu, cardiologist from Guntur, Dr. G. Shiv Srinivas Reddy garu, cardiologist, Dr. P. Sudarshan garu, cardiologist, Dr. P. Raghuram garu, cardiologist from Guntur. Please come on to the dais. Dr. K.V.N. Kamalakar garu, Rajahmundry, cardiologist from Rajahmundry. Please come on to the stage.
Now I request Dr. M. Raja Nagamahesh garu, consultant cardiologist, to come on to the dais and present the topic.
Good afternoon all. Myself Dr. Shahnaz, interventional cardiologist working as interventional cardiologist at Ramesh Hospitals, and my colleague Dr. Raja Nagamahesh will be also accompanying me. Now I would be presenting the 4 case scenarios and then I will be briefing them. This is 53-year-old male hypertensive diabetic presented on 11 July 24 with central chest pain associated with profuse sweating of 1 day duration. ECG was suggestive of anterior wall acute myocardial infarction showing echo RWMA in the LAD territory with moderate LV dysfunction. This patient has a past history of CVA, cerebellar infarct, for which decompression craniotomy was done in 2014. Patient had a history of unstable angina in 2021, for which ECG and echo were showing normal, and angio was revealing mild CAD, for which the patient was on medical management. These two are the angios. Like in 2021, it is like left main to LAD showing not significant plaque, but in 2024 he had been presented with acute anterior or myocardial infarction involving the distal left main and the proximal LAD lesion. This patient was taken up for the primary intervention and IABP was placed and the lesion was ballooned and the stenting was done. In the next case, it is 78-year-old male hypertensive diabetic presented on 19th April 2024, presented with chest pain on and off of 2 days duration. ECG and echo were normal study, so he has been advised for the CT angio. This patient had a past history of idiopathic thrombocytopenic purpura, having a strong family history, and he had already underwent PCI to the RCA with unstable angina in 2013. Then after, for other symptoms like syncope, he has been presented in 2023, for which he has been assessed with Holter monitoring, and CT angio was also done that time. It was showing mild CAD with medical management. This is a CT angio report showing mild CAD with a mild ISR of RCA 30%. CT angio done, which is on 19/4/24, which is showing LCX to OM3 lesion. It is of 80 to 90% stenosis. Advice for OCT guided intervention. These are the CT films that I have shown here. This is the lesion. This is the lesion in 23, which is not significant, of area stenosis of only 30%, with CT FFR showing 0.81. And this is the lesion that has been showing in 2024, which has an area stenosis of 80 to 90%, CT FFR revealing 0.77. For this patient, he has been taken for the intervention. OCT was done, which was showing like low attenuation plaque with 420 and with a thick fibrotic plaque, and PCI was done. And these are other two case scenarios. It is 60-year male patient with a strong family history of coronary artery disease, hypertensive and diabetic. Echo was normal. Calcium score was done, which is 2.8. In 2012, LAD was the same, and 2021 it is the same, even with the risk factors. This is the other case of 57-year male, smoker and diabetic. In 2013, it was showing a soft plaque in the LAD of 30%, and it is the same in 2018, with a distal bridging also is noted in this CT angiogram. So I would like to discuss these 4 case scenarios. Like these are the 2 sets of case scenarios. One is showing the rapid progression of the plaque, and the other is showing like even with a 10 years gap or approximately 5 years gap also there is no plaque progression. Then after, like with the same risk factors, these patients are having like smoking, diabetic status, hypertension. Even with family history status also, the plaque progression was very different in these case scenarios.
Yeah, that's the beauty of coronary artery disease. Only that much is remaining. Otherwise it becomes very boring, routine stenting lesion, it becomes further boring. As such it is boring. So that is the only enigma of coronary artery disease is left. Some patients behave different. That's where we need to exercise our caution. Most importantly, history analysis of the patient is most important. Patient, whatever may be the disease pattern he had before, presently he comes with you a classical angina. Don't neglect it. Whatever the CT angio showed before, normal coronaries also before, still you evaluate fully like how that patient had left me totally normal, thinking that it was normal. If you neglected, you would have further developed MI. So that's why clinical evaluation at that particular point of time is most important. Number 2, consider all patients with mild plaque, severe plaque as any atherosclerosis evidence in the body, not only the coronary arteries, peripheral arteries, even the carotid, anywhere it should be considered as high risk feature. It is indicated for high dose statin therapy. There is government guidelines also. So don't neglect any 30% plaque, 20% plaque in carotid or coronary. You should treat it as if he has high atherosclerotic burden. The same thing is applicable even for diabetic individuals. Diabetes is also considered as coronary artery disease equivalent. So consider it as having patient mild disease and treat with high dose statins. So these are some of the things by which if you follow, in spite of following all this, occasionally you could land in trouble, that is a different story. But this variable nature of disease presentation is seen. And once a patient has exceptions, what I say is, some patients have ectatic coronaries with slow flow, documented before, with some plus minus anginal or doubtful angina, like what you call syndrome X or slow flow. That sort of patients, I feel, continue to have the same presentations and coronaries continue to remain the same, provided they're taking some statin and other things. But for that, any mild disease is not a full proof that disease has not progressed now. On the other hand, should be extra careful to see that disease has progressed unless proven otherwise. These are the case examples which show that, and all of these patients should be treated with high dose statin.
My colleague
This is presented to understand or to know how frequently, supposing you see a 60-year-old guy with around 40% stenosis, how frequently you should re-visualize or re-image, or if whether it should be done with the CTCA or invasive angio, if the patient has got no risk factors, 1 risk factor, 2 risk factors or 3 risk factors. And similarly, a 40-year-old guy, if you have seen, let us say 100 calcium score and 1 or 2 risk factors, patients are asymptomatic. Don't depend on symptoms, we know that. And if the patients are asymptomatic, what are the guidelines say? How frequently you have to do this? What is the natural progression by your MESA score or your calcium consortium or Hinge-Nixdorf? A lot of trials are there where they followed for 15 years, 20 years. Now you know how the lesions progress on an average. So they have fixed up some guidelines, like for diabetes they say 3 to 5 years, again based on associated risk factors and age. So likewise, what is the warranty period for a normal fellow, normal 48, 10 years, people say 10 years, right? But then every patient should you do invasive angio or CT angio again? No. Probably in such patients, as you were mentioning, if the patient has no symptoms, if this patient has got absolutely okay, then probably a calcium score and asbestos. Well, this will prevent us from doing it every 3 years or 5 years CT coronary angio. That is my doubt. I just want to listen from you people also.
The guidelines said 2 years is a guarantee period or warranty period, whatever. If patient wants to know it after an angiogram or a CT angio, present guidelines, chest pain evaluation guidelines 2020 ACCH said 2 years is the period by which at least you can assure patients. After that, there is no guarantee. But 2 years also, we have seen some patients 1 year later also developing. But what guidelines mentioned is a 2-year period. But as you said, if a patient, you have to be absolutely sure the patient is asking you directly and he wants to know everything and wants to spend money, that is up to him. But otherwise, by and large, I feel reasonably we can predict by patient's symptomatology and treadmill, and even if you do CT, comes 20%, 30%, I want you to be aggressive on treatment. That's what is the message I want to give.
So here we look into why some people are progressing so rapidly and why some people are remaining stable. We try to look into the literature, and we all know that atherosclerosis, it is like accelerated atherosclerosis and spontaneous atherosclerosis. Accelerated atherosclerosis is usually seen in cases of CABG, post-PCI or post-cardiac transplant patients, whereas spontaneous, it usually occurs in the normal aging population. The third variant, which is this rapidly progressive atherosclerosis, this is seen in a separate set of patients. It's how we are going to define this rapidly progressive atherosclerosis. If we have a baseline study and if the lesion, a pre-existing lesion is more than 50%, and if it progresses to more than 10% diameter reduction, then we are going to say it as rapidly progressive. And also, if the pre-existing lesion is less than 50% stenotic and it progresses to more than 30% diameter reduction, that's also a rapidly progressive lesion. And also, if there is a progression of lesion to total occlusion over a few months period of time, this is also defined as this rapidly progressive atherosclerotic lesion. So what are the patient's characteristics who are going to show these rapidly progressive atherosclerotic lesions? So the factors affecting this plaque progression are, one is coronary spasm, and associated with this coronary spasm, if there is intramural hemorrhage, and also complex lesions with irregular borders, overhanging edges and intracoronary thrombus, and also spotty calcium on CT, which is less 1 to 4 mm in length, and also arch circumference of less than 90 degrees. It's also a CT feature which favors a rapidly progressive nature of the lesion, and also elevated inflammatory markers like endothelin, lipoprotein A, and lipoprotein associated phospholipase A2, and neopterin, matrix metalloproteinases, ICAM, CRP, and HSCRP. These are the factors which are going to affect the plaque progression, whether it's going to remain stable over a period of time or it's going to, these patients are going to have a rapid progression. And here we can all say these are all, they lack specificity. Like each of these factors can be present in, each patient can have multiple factors, and also every patient can have 1 or 2 factors. And also they lack specificity to say who are rightly going to progress, who are not going to progress. So how are we going to address this specific population? One is residual cholesterol risk, that is LDL more than 100%. In such cases, we are going to treat with PCSK9 inhibitors or inclisiran or hydrostatin or adding ezetimibe. And residual inflammatory risk, if the HSCRP continues to be more than 2 mg per liter, then we are going to target inflammation. And studies like CANTOS and LODOC, where they have studied adding colchicine to the treatment regimen, whether it reduces the risk of progression. And also the residual thrombotic risk, which is addressed by newer antiplatelets like ticagrelor or prasugrel, and also residual triglyceride risk, where triglycerides are more than 150 mg per deciliter, like we are going to add finofibrate to the therapies. And residual lipoprotein A risk, if the lipoprotein A levels are more than 50 mg per deciliter. We know till now there is no specific therapy which addresses this increased lipoprotein A, but inclisirans are said to have some amount of effect on the reduction of lipoprotein A levels. And the residual diabetic risk which the patient carries, where we can add like liraglutide, like GLP-1 agonists, or SGLT2 inhibitors like dapagliflozin or empagliflozin. And the lipid levels, these PCSK9 inhibitors, they have multiple effects, like they reduce the lipid levels and they reduce the amount of inflammation, they stabilize the plaque and they decrease the plaque progression and they decrease the risks. So the key takeaway is assessing the plaque and assessing the patient, that risk factors the patient is having, whether these risk factors will cause the rapid progression or the disease might remain stable, and assessing the nature of the plaque on CT coronary angio or intravascular ultrasound or radiofrequency intravascular ultrasound to decide the nature of the plaque and decide on interval of screening. If the patient shows high risk characters, screen within 3 to 6 months, or like if the patient is relatively stable, 1 to 2 years. Thank you.
In other words, we are talking about the other risk factors which need to be considered, like lipoprotein A or CRP or some other biomarkers. For example, chromosome 9p21 is there, which has a genetic preponderance, predilection, and there are about 100 to 200 genes now which are being identified. So the other genetic factors, and then your molecular biology, which now in future the quantum computing is studying every cell, cellular atlas, whole cell atlas. So all these things in future will identify the prediction model who is likely to develop the progression of the disease like this you are seeing, and also the perivascular fat attenuation or inflammation or the high risk plaque. It may detect some more features of high risk plaque, your CTCA. So that is what you are saying, that there some risk factors which are known and unknown are there, and it is highly unpredictable what you have shown. See all these 6-7 patients. These are my patients. In fact, 2-3 are my patients, where I was expecting, the obese, smoker, diabetes, obese, nothing. So I thought after 7 years I am doing. So I'll be finding some double articular cell disease. In fact, the lesion has regressed. It was 50% earlier. It was 30-40%. You have seen that, right? So it was a surprise to me, pleasant surprise only, because he is my close friend also. So likewise, it is uncertain. And then you have shown one doctor also that she come. The doctor 95%. So from say 60 or so, 95%, he is asymptomatic. Your CTFFR is 0.73, and you don't know what to do. And he is playing shuttle regularly. You don't know whether he will drop dead suddenly. And then he is asymptomatic. Pressure is negative. So we are not doing this. So intracoronary collateral, some microvasculature, something is there which is protecting him. So some nature, as Srinivas says, some nature has to protect you. You can't predict.
God is great. Lighter way I'm telling, when one patient progressed, I was asking, what happened to you, man? You were so normal, what happened? He's pointing to his better half saying, see that this reason is being in front of you, sir. What to do is, thank you.
I would like to add a word here. Only when there is a plaque, there is a progression. So primordial prevention should be focused.
Best.
Means generation should be started from birth. Primordial prevention should be taken care definitely. Thank you.
Good. Thank you. Ramesh sir, but for all these, no, what we say is consider as if it is progressing only and treat it. That's the only thing we can do because it's unpredictable. What we can do as clinicians is treat all of them as if they are about to progress. If somebody is not progressing, he is lucky. Well, that's how we have to balance things. So what do you feel? Yeah, that is it. Yes. Yeah, that's what I told in the earlier discussion. That's what I told in the earlier discussion. If you show the plaque, at least they will take. But in this plaque progression intensity variation, what I am feeling is everybody should think that it will progress and treat aggressively. That's what we can do as clinicians. Aggressively decrease for everybody, I am saying. What I am saying is aggressively decrease for everybody, thinking that they are about to progress anyway. That's what. Because these patients are documented disease before, aggressively treat so that fortunately you're not progressing, also good. Otherwise also it's okay. Because statins, I don't think they're that dangerous to be worried of. Many of the times, I think clinicians, cardiologists at least, if you have come out of that fear that statins will cause multiple problems. If somebody is averse to statin, now you can take the help of other long-acting injections too. Think any other things in this?
And to comment in research or is there income letters?
I was presenting a case to senior cardiologist. I was presenting like a Bahubali movie, stepwise. So, but she was not like amused. You want a short history, but every time they visit to you, you need to take his history. So there will be a change in plaque behavior because of his behavioral changes. Some psychosocial risk factors, some economic issues, some job loss, or some social issues, marital issues. These things may turn him into a stable plaque to inflammatory myeloma. So we should not forget that atherosclerosis is an inflammatory disease. End of the day. So, and we are not treating coronary severe with statins or maybe low dose antiplatelets in a low risk scenario. We need to take a holistic approach and we need to reassess. Especially this is often forgotten in a post-CABG patient. So post-CABG patient, we think he's safe for at least 5 years or 10 years. That is not always the same. They succumb to ACS within 5 years also. So repeat history taking, how is his sleep pattern, whether he is able to take adequate sleep, and whether he is able to maintain the lifestyle, not alone adopting, maintaining and sustaining the healthy lifestyle, adequate sleep patterns, and all these, whether he is able to follow yogas, all these exercises. This is also important to predict plaque progression. Apart from these HSCR.
One word of caution, sir, for practitioners who are sitting, post-bypass, many of the surgeons have a habit of continuing. I am not against the surgeons, don't think that way. They have a habit of following, only echospin one tablet will be written. That is not correct. It's better to send them back to the cardiologist who will take time to evaluate and give proper high-dose statin or whatever is required. Because it's also a form of revascularization. Though adaptive may not be that important, but secondary prevention risk factors, giving high-dose statin is equally important. By some surgeons who are non-operating surgeons do very good medical practice. That is okay. But for busy surgeons, many of them, what I have noticed is echospin just continues. That is also not correct practice. I don't know what is followed in your hospital.
Yeah, we feel that every 5 years at least a CT coronary angiogram should be done for
No, follow
bypass.
with cardiologist or cardiac surgeon, I'm saying.
Most of the times we follow, but
Yeah.
even if the cardiologist, CT surgeon should be sensitized that every 5 years you should do, because even diabetic patients you are doing for 4 to 5 years is the
Yes,
recommendation. Already established CAD, TVD, you have to do every 5 years. Even for stents, at least more than 2.753 millimeters CTCA with FFR, now at least it should be helpful along with the, because you can't do again invasive FFR and all. Even post-PCA patients we should do, because in other vessels we keep seeing sudden silent progression. We ask them to get it done, 95% proximal LED, anytime he will drop dead. So we think, okay, second heart attack, ho gaya. But it could have been prevented. So this is every 5 years at least we should do.
This,
apart from treadmill.
because you are also entrepreneur, owner of the hospital, I am telling, some of the surgeons have the habit of taking one-time fees and they don't charge follow. Patients will come, namaste, they get available with surgeon because he doesn't charge, where the cardiologist is paying, he has to pay the consultation charge. That is not a question of consultation charge, but it's doing disservice to patients, I feel. Because surgeons don't bother to see all the medicines were taken or not. LV dysfunction patient, circulatory valsartan is not given. The guideline related medical therapy is not given, because I don't blame them because they are not experts in it. But at least follow-up should be precisely done by a cardiologist. At least if you put a cut-off 1 year, it's okay. As long as surgery, healing and all that, they can take care. But later on, it should be followed up by cardiologists, I feel.
Otherwise, how will surgeons survive? See, they have to depend always on you if they send the patients back. If the patient says, I am operated by him for 20 years, I haven't seen the face of Srinivas Kumar, surgeon will be happy, he will be promoted also.
So one more thing is, surgeons do a very difficult job of operating on still it's a fairly invasive procedure with lots of morbidity. Many of them tell, I have grafted everything, 25 years guarantee. So immediately I tell, after they come back to me, they will tell you 25 years guarantee to cause of solace for you, so that you have recovered some happily from the procedure. Because once you are a diagnosed coronary artery disease patient, you are a very high risk, especially CABG is done on a proximal or left main disease with triple vessel disease often. So you are a very high risk patient, and very high risk not only for coronaries. You may be having a risk of stroke, you may be having a risk of peripheral artery disease. So holistic approach matters. Yeah, that's why I tell sir. No sir, my personal feeling is you need to have fear. You need to have a fear to live long.
We'll get on to the next section. Thank you for
Panelists. Sir, small mementos to panelists. Just a second. Dr. Sudarshan sir, please come on to the stage.
Good evening, everyone. With the permission from Dr. P. Ramesh Hospital and the Aster Hospitals, Aster Ramesh Hospitals, I am Dr. Srinivas Chaudhary, Head of the Department of Cardiology, Ayush Hospital, and we are conducting AP Society, Cardiological Society of India AP Chapter Conference at NRI Medical College next month, that is on July 18th, 19th and 20th, these 3 days. with eminent faculty like Prasad Rao Garu, Gokhale Garu, and Srinivas Kumar Garu, to name a few. I sincerely thank the Ramesh Hospitals and Ramesh Garu again for giving me this opportunity.
Now we have a small felicitation. Now I call upon Dr. S. Keshavara Babu sir, observer from APSC, AP Medical Council. Sir, please come on to the dais. I invite Dr. P. Ramesh Babu sir to felicitate Keshavara Garu. He is a AP Medical Council member and observer for this CME.
కూర్చోండి. ఉండలేనా సార్ అది మళ్ళీ వస్తున్నట్టుంది. లైట్లు ఉంచండి నా లైట్లు
వేరే లైట్ ప్లాస్టిక్ పడుతుంది అలా కనబడుతుంది, అది ఆపమంటున్నాడు అన్న.
అది ఆపన్నా ఏదో ఆపుతుంది. లైట్లు వేసామన్నా ఏంది వీళ్ళు కోమలు లైట్లు ప్లాట్ఫారం లైటింగ్స్ వెళ్ళే ఉంటాయి నీట్గా స్టేజ్ లైటింగ్ అన్నీ.
Now I request Dr. R. Kirtika, Dr. Subhash, Dr. Varun Mitra, Dr. Sai Krishna and Dr. K. Tirupati Rao Garu to come onto the stage as panelists for this session.
బ్యాగ్ తీసుకో.
Now we invite Dr. S.V.K. Ramakrishna Garu to come onto the dais and present the topic.
Dr. Chandramani, start up this.
We'll start the session. The first topic will be the left bundle spacing in whom by Dr. S.V.K. Ramakrishna. He is an electrophysiologist from Care Hospitals, Hyderabad.
Thank you. At the outset, I would like to thank Ramesh sir for inviting me to share our experience with this in this forum. Thank you so much, sir. Just to change gears, away from coronaries, a word about arrhythmias. So, my topic is conduction system pacing, which patients to select and why we should select. So, cardiac pacing has gone a long way, starting from the initial septal pacing, apical pacing and all. Things took a big turn after biventricular pacing and his bundle pacing came into picture. Even though his bundle pacing was described in 2000, it was not till 2017 when left bundle pacing was described first. Only after this landmark paper by Huang et al., conduction system pacing has come into particular vogue. Why we should think about conduction system pacing? In short, if you see the normal heart, all the ventricular myocardium is activated by multiple Purkinje fibers. It is like a synchronous activation of the entire left ventricular myocardium by a vast network of Purkinje fibers. Just contrast that to the normal septal pacing, where we put one lead in the septum or in the apex, and we are forcing the entire ventricular myocardium to just depolarize from this. So we are actually taking a synchronized heart and giving it a complete desynchrony. So no wonder myocardial pacing causes mechanical dysynchrony and systolic dysfunction. In the long run, they develop atrial fibrillations, valvular regurgitations, and heart failure. So the options are to upgrade to the biventricular CRT or a his bundle pacing or a left bundle pacing. We all know that pacing-induced cardiomyopathy is a significant problem. Almost 20 to 30% of the patients with septal pacing develop, myocardial pacing develop pacing-induced cardiomyopathy. As the pacing burden increases and as the duration since the implant increases, the systolic function reduces. This is a significant problem in our routine practice. So how to synchronize the heart? We have taken multiple approaches. One, of course, is a conventional biventricular pacing, which is an epicardial pacing through the coronary veins. Now we have a lot of other possibilities. We can pace the his bundle, we can pace the left bundle, or we can just pace one of the branches of the left bundle, or maybe a deep septal pacing. Procedure-wise, it is fairly relatively easy, simple procedure. We need an additional sheet to position the left bundle lead. After the description of left bundle pacing, his bundle pacing is not practiced. Most of the time, almost 100% we are doing only left bundle pacing. A word about the procedural details. We have to track the electrograms. It is always better to do a left bundle pacing with the EP system connected. Without the EP system connected, you may not get the appropriate parameters. So, today, when we talk about the routine dual chamber, whether it is apical or septal pacing, it is non-physiological pacing, and as we go from biventricular pacing to left bundle, probably his bundle and left bundle are the most physiological pacing that we have today. So we'll share a few of our case examples. This was one of our first cases, wife of a doctor, very senior ophthalmologist, a 55-year-old lady. She was under our follow-up with a known left bundle branch block for more than 5 years, wide QRS, now presented with low ejection fraction, class 3 symptoms of recent onset. Angiogram showed no significant coronary artery disease. It was our practice to do cardiac MRI for all these patients initially. It didn't show any significant scar. So this is a typical patient with a left LBBB-induced cardiomyopathy. So the options of a CRT versus left bundle pacing should be discussed with these patients. Because there is no significant scar, we can think of a CRT-P or a left bundle pacing. So this is the ECG of this patient. It's a typical left bundle branch block with a wide QRS. This is something similar to our well-known ladder diagrams. This is a normal heart where both the bundles synchronize simultaneously. When the patient has an LBBB, it is because of the transmyocardial conduction that the QRS widens. The same thing happens when we do a RV pacing. Because of the transmyocardial conduction, the QRS widens. when you do a his bundle pacing or a left bundle pacing, you are actually recruiting the left bundle fibers, and thereby you are ensuring a synchronous activation of the left ventricle. So the QRS is going to be narrow compared to the baseline. So this patient underwent left bundle pacing. This was one of our first cases. You can see the very typical narrow QRS with a RSR- pattern. This patient did very well. Her ejection fraction came back to almost normal, 55%. She is under our follow-up for almost 5 years now, and she is doing very well. This is another case scenario where left bundle pacing, physiological pacing may be useful. This is a patient, a 67-year-old female with a congenital transpositional great arteries with a complete heart block. Now the problem is her systemic right ventricle is severely dysfunctional. She has moderate MR. Now obviously this patient needs pacing, but if you do a routine RV septal pacing, we may actually worsen the systemic dysfunction. We can think of a CRT, but the problem is because it's a congenitally abnormal heart, we may have some significant anatomical differences. So we thought we will do a left bundle branch pacing. You can see this. This is the pacing ECG. Unless we see the paced complexes, unless we see the pacing spikes, we cannot recognize that this is actually paced ECG. So it's such a narrow QRS complex, and this patient is doing well for over 3 years now. This is a very interesting patient. A 62-year-old lady presented with a symptomatic AV block. Baseline, she has an LBBD with a wide QRS of 150 milliseconds, good LV function, normal coronaries. So we did a routine RV septal pacing for this patient. At that point of time, it was not a routine that we were doing conduction system pacing for all patients. So we did a normal routine septal pacing. QRS is not very bad, but this patient came back to us after a couple of weeks with acute LVF, with moderate LV dysfunction, moderate to severe MR. It actually looked more like the dysynchrony of this thing which has worsened. She presented with LVF, coronaries were again normal. What to do? What happened? So we had a lot of discussions on this. There was, we didn't have any particular another etiology to suggest coronaries were normal, drop was negative. We didn't have any other issues with this patient. We thought it is a stress-induced cardiomyopathy. We waited for 1 week. She was not improving. So then we changed the septal lead and we did a left bundle pacing lead. So again we can see the narrow QRS, which is very narrow, almost quite, it looks like an almost normal ECG unless we see the pacing spikes here. This patient improved remarkably after this thing. Her ejection fraction came back to normal. She is on follow-up for over 2 years now. My last case scenario will be an 82-year-old male. This is a known ischemic cardiomyopathy, post-PCI, long time back. He has severe LV dysfunction for quite a long time. He was having recurrent heart failures for the past 1 year, very low ejection fraction of 22%, moderate MR, some PAH with CKD and COPD. Now this is an extremely high-risk patient for any kind of resynchronization, considering his age, CKD and other comorbidities. This is not a typical LBBB. You can see the notching. This is more like intraventricular conduction defect. So when you have LBBB with IVCD, in a normal CRT, when we do a normal CRT, it is a fusion between the right and the left bundle activation, which tends to narrow the QRS. But with an IVCD, what happens is, if the lead, the left one, the coronary sinus lead, if it is pacing near a scarred area, or if we do not have significant viable myocardium, this is not going to help us. So it is only through the RV pacing that the left bundle will still be activated. So the QRS will still remain very long. So in the presence of intraventricular conduction defect, conventional CRT alone may not work properly. So when we do something called as a lot CRT, where we put both a left bundle pacing lead and a CRT lead, because we are recruiting the left bundle fibers as well as the lateral myocardium, we get a fused QRS that is comparatively narrow as compared to the baseline. So lot CRT is one of the techniques which helps us in managing these patients. So this patient underwent a lot CRT, a reasonably good QRS complex, narrow. This we did as a workshop case a few months back. His ejection fraction improved to around 34-35% as of now. He is symptomatically class 2 and he is doing well. He didn't have any heart failure in the past 9 months. So to summarize, conduction system pacing, or what we call as physiological pacing, is a very effective pacing modality with wide applications. Definite clinical scenarios where it will be useful, or it is an effective resynchronization in patients with LV dysfunction and LBBB without any scar, the kind of patients that we have seen as our first case example. Also as an example, as an adjunct to CRT, as LOT CRT, as we have seen with our fourth case example. It is always an effective pacing strategy in patients with borderline LV function, where we have mild to moderate LV dysfunction, patient with complete heart block, where we have to do pacing, but we don't know whether a routine RV pacing may actually worsen her LV dysfunction. So this is the group of patients where this will be useful. And it should always be considered as a pacing modality in patients with good LV function and who have a baseline very wide QRS, like our third case scenario. So this is one subset of patients which we are thinking actively at this point to consider for conduction system pacing. Also, there will be very few patients with permanent atrial fibrillation where we have to do AV junction ablation. In those patients, you can always use conduction system pacing as a pacing strategy. Whether we should use conduction system pacing in all patients, we still have to wait because we don't have the long-term data. As we have seen, CSP has been, left bundle pacing has been around for only the last 7 or 8 years. We don't have the long-term data to show, but once we have long-term data, probably it will become the treatment of choice for all patients with pacemaker indication. Thank you.
Any questions? If there are no questions, we will move to the next topic. Next topic will be arrhythmias in electrophysiologist's perspective, a case-based discussion by Dr. Rakesh Dulba. So he is a consultant electrophysiologist from KR Vizag.
Good evening, one and all. At the outset, I would like to thank the organizers of this fantastic program and specifically Ramesh sir for giving me this opportunity to present a few minutes regarding arrhythmias in front of my senior colleagues. So in the next few minutes, I will be walking you through the workflow which we follow in the electrophysiology laboratory to approach the arrhythmia and treat it. So as we all know, the mechanisms responsible for arrhythmias are usually categorized as disorders of impulse formation in the form of automaticity or triggered activity, or disorders of impulse conduction in the form of re-entry, or a combination of both. So the diagnosis of underlying mechanism of arrhythmia, it helps in guiding appropriate treatment strategies. So certain aspects like mode of initiation and termination of arrhythmias and response to programmed atrial and ventricular stimulation are commonly used in the laboratory settings to distinguish among different mechanisms of arrhythmia and to treat them. So the common workflow which we usually follow in the EP lab is to obviously know about the clinical details and coming to a working diagnosis based on the ECG interpretation, and in the laboratory we try to initiate the tachycardia if the patient is not in tachycardia, or if the patient is in tachycardia already, we will try to map it, and then follow the mapping of the tachycardia, establishing the origins and the mechanism of tachycardia, identifying the ideal site to terminate the tachycardia, and confirmation of successful termination and assess the risk for recurrence and post-procedure management. So by and large, for every case which we take up for the EP lab, this is the usual protocol. So I will be discussing about two case scenarios which will be pointing to the most commonly seen cases. In the case scenario 1 is a 68-year-old male. He is obese, hypertensive, diabetic with history of shortness of breath at rest and with history of swelling of feet and abdominal distension progressing for the last 6 months. He was found to have tachycardia on routine evaluation. Echo which showed moderate left ventricular dysfunction, underwent coronary angiogram elsewhere which showed normal coronaries. Referred for further management. The initial impression was heart failure with reduced ejection fraction with possibility of underlying tachycardiomyopathy. So this is the ECG which is showing this is the ECG showing a narrow complex tachycardia with an irregular ventricular rhythm and with inverted P waves in leads, inferior leads 2-3 AVF and upright P waves in lead V1. The typical sawtooth pattern of the P waves in the inferior leads is suggestive of atrial flutter. So for the novice, the atrial flutter P waves, it is commonly seen in typical counterclockwise flutter. The initial deflection point is activation of the cavo-tricuspid isthmus, which is just besides the coronary sinus ostium, which is the important prerequisite for the development of atrial flutter. And the abrupt downstroke is because of the activation of the cardocranial activation of the interatrial septum, and the upstroke and the peak is because of the activation of the right atrial flea wall, which is from the craniocaudal direction. So the flutter waves is the typical counterclockwise atrial flutter is the most common form of macro re-entry atrial tachycardia which usually we come across. So typical counterclockwise atrial flutter, typical atrial flutter is of several types, but the most common thing which we usually see is counterclockwise flutter. And the other types of flutters are clockwise flutter, lower loop re-entry and intraisthmus re-entry. So the patient was taken into the lab. The patient is already in, patient is already in tachycardia. If the patient is not on tachycardia, we usually do a programmed atrial stimulation to initiate the tachycardia. So so after taking the venous axis, we put a coronary sinus catheter which spans across the coronary sinus, the proximal and the distal one. The proximal coronary sinus is usually in the right atrium and the distal coronary sinus is usually in the left atrium. So these are the electrograms which are recorded from the proximal coronary sinus, and these are the electrograms from the his catheter, and these are the chest leads which are placed on the patient. So the proximal, the coronary sinus activation will let us know what exactly is happening. So here, if we see the proximal coronary sinus electrograms are comparatively earlier compared to the distal coronary sinus electrogram. So it indicates that the wave of progression is from the proximal to the distal coronary sinus, which is in the form of entering from the right atrium to the left atrium. So when we have taken up for the cath lab, this patient has a hugely calcified atrium, and possibility of constrictive pericarditis also is there. So we have done the patient under electroanatomic mapping, which is the 3D mapping. So after initiation of the tachycardia, we will map the tachycardia to see where exactly is the re-entry circuit located. So this is the mapping catheter, and in the 3D electroanatomic mapping system, we will take a reference catheter, which is the coronary sinus catheter, which is usually taken in the supraventricular tachycardias. And after the mapping catheter and reference catheters are assigned, we will map the certain important points which are necessary for the circuit of the atrial flutter in the form of superior vena cava, inferior vena cava, tricuspid annulus, and the cavo-tricuspid isthmus, and the his bundle region, and the whole right atrium. So while the mapping catheter is rowed along the coronary sinus, so we measure some we take the electrograms from the right atrial level, and we measure the local activation times, and we'll collect several points and we'll take a window of interest also. In the form, for macro reentry tachycardias, we'll take at least 90 to 100% of the cycle length as the window of interest, and we'll take a reference electrogram. As I mentioned, in supraventricular tachycardias, we take the reference electrogram as the atrial electrograms in the coronary sinus catheter. So, after the mapping is done, sorry, I couldn't. Based on the local activation times, there will be several color coding will be given to the electrograms in the form of purple, blue, white, and green. And the early meet late pattern is commonly seen in the re-entry circuits. So now we also does entrainment procedure during the mapping to know where exactly whether the atrial flutter circuit is involving the left atrium or the right atrium only. So we'll do entrainment map. We'll try to enter the circuit of the atrial flutter by pacing the proximal coronary sinus electrode, which is there in the right atrium, and we'll see the onset of the tachycardia. If the pacing post pacing interval is less than 30 to 50 milliseconds, it indicates that we are within the circuit of the atrial flutter. Here we have done from the distal coronary sinus electrode, which is the left atrium, which is more than roughly around 60 milliseconds, which is suggesting that the left atrium is not part of the circuit. So here, after mapping the whole tachycardia, we could establish that this is a propagation map of the entire right atrium, including the superior vena cava, IVC, cavo tricuspid isthmus, and the tricuspid annulus, showing a counterclockwise activation of the interatrial septum. This is the right anterior oblique view and the LAV view, showing the counterclockwise activation of the flutter circuit. So then we will decide the ideal site to terminate the tachycardia. Here in typical counterclockwise flutter, because the cavo tricuspid isthmus is the area of slow conduction, we will map the cavo tricuspid isthmus is located from the tricuspid annulus till the origin of the inferior vena cava. So we will continuously give radiofrequency burns in the region of the cavo tricuspid isthmus and see the attenuation of the electrograms. And while we do the cavo tricuspid isthmus ablation, you can see that these are the atrial electrograms which are faster, and after a certain point, while giving the radiofrequency current, the flutter got terminated into sinus rhythm. So this is the same. Here the flutter got terminated into sinus rhythm. So after that, we'll confirm the successful termination of the tachycardia in the form of confirming the bidirectional block. So we will pace from the coronary sinus and we'll see whether how much time it is taking for the pacing impulse to reach the cavo tricuspid isthmus, and if the bidirectional conduction is more than 150 milliseconds, it is suggestive of a successful CTA ablation. Few minutes. And post pacing, the patient is in sinus rhythm. Last few slides. Patient is in sinus rhythm, and we followed the patient up. And this is my case scenario 2, suggesting a focal tachycardia. So 50-year-old male who is a hypertensive, history of occasional palpitations and pre-syncope for the last 2 years. He was in follow-up with me, but I advised him a halter, but it didn't reveal, but only revealed an occasional VPC as I have put him on medical management. In March, recently he presented to the OPD for routine follow-up and was complaining of recent aggravation of symptoms. So I have sent him for the routine ECG, but to my surprise, and his LV function is normal, I advised him EP study and RF ablation. To my surprise, during the ECG, the patient had documented tachycardia which the halter couldn't pick up. So here there is one single VPC with an outflow tract morphology, and then this ECG is showing positive QRS complexes in the inferior leads, lead 2 and AVF, and a left bundle branch morphology, and with transition at V4. So suggestive of a outflow tract tachycardia. So I have taken him up for the ablation. He had non-sustained runs of the same tachycardia which we have seen in the ECG. These are the electrograms showing some VA dissociation, and we have done mapping because we suspected the origin to be from the right ventricular outflow tract. We mapped the whole right ventricular outflow tract, and we have measured the local activation time, and we even do pace mapping in patients whom we are suspecting a focal origin of arrhythmia. And if pace mapping is more than 90% positive, and if the local activation time is more than roughly around 40 to 50 milliseconds earlier than the QRS, then we'll try to give a radio frequency current over there. So this is after ablation, and then after the final ablation, the patient is free of arrhythmia and is in follow-up right now. Thank you.
Nice presentations, Rakesh. So the next topic will be probably the last one for this day. Before the quiz, will be an ECG interpretation in the ear and how to avoid blunders by Dr. Krishna Prasad. He is a cardiologist and electrophysiologist from NABH Hospital in Mexico.
The most cerebral topic is pushed to the last when the mindset. So I discussed the basic ECGs only. So the basic ECGs we face in emergency. So before that, I will thank Ramesh for this opportunity. So the first ECG will be the bread and butter of cardiologists. So he's a 39-year-old male, he's a chronic smoker and presented with normal vitals, and he has only tachycardia. So this is the ECG we see regularly in our emergency practice. So we can see the patient is having sinus tachycardia, normal axis, sinus rhythm with 1:1 AV conduction. So what is more significant is the presence of ST elevation from lead V1 to V4, more than 4 to 5 mm ST elevation. So contiguous leads, more than 2 leads having ST elevation, we call it ST elevated anterior wall MI. So obviously we see when a patient presents with chest pain, we see ECGs of ST elevated anterior wall MI. So there are some mimickers which we often miss when they present to emergency. So those ECGs we should not miss. So I would like to point few ECGs which we face during our emergency, and we tend to miss those ECGs and label them as MI or not MI. So we'll start with this. So imagine this patient is this patient is a 38-year-old male who presented to emergency with chest pain. So many times we have studied in books that how an anterior wall MI evolves. So they start with peaked T waves, tall T waves. Then they start developing ST elevation MI. And if you don't treat it, they develop Q waves and T wave inversions. So I'd like to show how an MI progresses. So many times when the patient is really aware of his disease, he comes to emergency with these kind of ECGs. They present with tall T waves. So most of the ER physicians might overlook because there is no ST elevation, there is no ST depression. So but we can see how this ECG progresses. So later there will be subtle ST elevation, and 1 hour later he will have a tombstone kind of appearance of ECG. So this is the same patient, and we would have taken the patient for primary PCI way back when he presented with tall peak T waves, but the ear physician missed and he developed tombstone, and later he had to develop QST and QST elevation and T wave inversions also. So what are the mimickers? So imagine you are a 35-year-old male smoker with one episode of syncope 1 week back during an episode of acute febrile illness. So when a patient present to emergency with chest pain, which is doubtful chest pain, and presented with fever. What can you see? Scoving pattern of ST elevation and the ST changes were not progressive. Like the first ECG I showed, where ST changes from peak T waves to ST elevation, there was no progression in this patient. And there were obviously no reciprocal changes in the inferior leads. So there are types of group, there are type 1, type 2, type 1 and type 2. So this is one more ECG. So this probably is one of the greatest mimicker of MI. So in this ECG you can see this also patients present with chest pain. However, the chest pain will be radiating to the shoulder and it will be aggravated on deep inspiration and usually preceded by a fever episode. So there is gross ST depression, multiple leads which is not fitting into any coronary territory, and there is PR segment depression and AVR there is ST depression. So when you see this kind of ECG, you should not think about ST edema, you should think about pericarditis. So now I will present a case where is one of the great mimicker in cardiology. This disease can present as present as acute coronary syndrome, acute respiratory failure. So this patient, otherwise just a smoker, with presented to emergency with tachycardia and hypoxia. He presents with this ECG. So what all we can see in this ECG? So starting with basic ECG reading, there is sinus tachycardia, and if you see the sinus tachycardia, which is the axis, it is right axis deviation, and there is, if you see the chamber sizes, there is clear cut right chamber enlarged, and this is RV strain, incomplete RBVB, and presence of T wave inversions from V4 to V6. All these point towards RV strain, and like we all mention often, there is an S1Q3T3 pattern in pulmonary thromboembolism. Even though it is less often seen, they keep on mentioning, we can see S1Q3T3 pattern in that also we can see here. There is S in lead 1, there is Q wave and T3 T wave inversion in lead 3. So when patients present with subtle signs of sinus tachycardia and hypoxia, with especially younger subset, presence of DVT, long flight travels, long history of long travels, should start suspecting pulmonary thromboembolism. So few ECG, what are the signs in ECG? Sinus tachycardia is most commonly seen, and the most commonly mentioned S1Q3T3 pattern is only seen in 20% of the patients. So a 30-year-old male, a fit individual, came to, you often see, though it's not an emergency, you often see in OPDs, the young male presents with chest pain. Then you start seeing this ECG. So maybe if it's seen by any physician, they'll say it is an ST edema and often call the cardiologist and refer to them. You can also, obviously they are not wrong, you can see ST elevation in inferior leads and later leads. The catch point is there is no tachycardia, there is a relative bradycardia, and the chest pain might not be severe. And if you repeat the ECG after 1 year, it remains the same. So this is an early repolation kind of variant. It is because of the repolation abnormality. The catch point is the presence of notch. The notch is a very characteristic sign of early repolation, and even though ST elevation is less conspicuous, the notch is very conspicuous. Previously they used to call it benign repolation syndrome, benign early repolation syndrome, but even the studies published in NEJM say it is no more a benign syndrome. If the patient has syncope, recurrent syncope and family history of sudden cardiac death, you should also intervene them by putting an ICD. If the ST elevation is more than 2 mm in the inferior leads, there are a high chance of sudden cardiac death in these patients. So what do we see here? This also often tend to miss in ERs, emergency rooms. So it's a history of chest pain for 4 hours, a 45-year male smoker. So the ST changes are very inconspicuous. You can see there is a T wave inversion and ST depression lead 3, AVF, and ST elevation in AVL and V2. Okay. And one also there is ST elevation. So this is newly described pattern in ST elevation MI. It is called South Africa flag sign. So the ECG changes, if we arrange in this 12-lead ECG pattern, it looks like a South Africa flag, where there is ST elevation in lead 1 and AVL and V2, and ST depression conspicuous in, good in lead 3. So this is usually seen with patients who have a diagonal artery occlusion. Even though like the major artery or LAD or RC is not occluded, it is a kind of ST elevated MI where your diagonal is involved and a significant part of myocardium is at jeopardy. So this ECG is also often tend to miss in ERs. They consider it as non-ST elevated MI, but because of the diffuse ST depressions and ST elevation in AVR, this is a ticking time bomb, and it's usually a left main equivalent. So, I mean, in the new ACC guidelines or wherever it is, this kind of ECG pattern also they were telling to consider it as ST elevated MI. What are you seeing here? There is a diffuse ST depression from V2 to V6. If you keep on following this ECG, they might evolve into peaked T waves, ST elevated MI, and further ST elevated MI. So these people also should be taken to primary plasty. This is called De-Winter's pattern. The ST depression from lead V2, lead V6. This is also an equivalent of STMI. So MI part is finished. So we often see ECGs with arrhythmias in emergency rooms. So what is this? So to describe any normal ECG, this is not sinus rhythm. A narrow complex tachycardia, QRS duration is narrow. So less than 120 milliseconds. A narrow complex tachycardia is going on. A rate is approximately 170. And do you see any P wave in this? If you see very closely at the end of QRS or within the QRS, there is a notch, probably a P wave. So this is a narrow complex tachycardia. And probably if you go back and see, there is QRS alternance also. So what do you do in a short RP tachycardia with narrow complex tachycardia? The diagnostic and the therapeutic is giving injection adenosine. So people tend to avoid giving more than 6 mg adenosine. It is safer to give at least 12 mg adenosine. 18 mg adenosine we usually give during EP studies. So if you give 12 mg adenosine, it will revert to normal sinus rhythm. So what do we see here? This is also a common pattern seen in emergency rooms. These patients, they'll have baseline ECG like this. This is called WPW syndrome, Wolff-Parkinson-White syndrome, where you'll have a short PR interval, and QRS is usually wider because of the delta wave and secondary repolation changes in STT segment. Then we finish narrow complex tachycardia, then we go to wide complex tachycardia. This is the ECG we see in emergency rooms when the patient presents with hypotension in failure. You see this ECG, you have to immediately cardiovert the patient because these are like life-threatening situations, and patient will have immediate collapse if you don't intervene. So how to identify a QRS duration more than 120 milliseconds with rate more than 100. They are called ventricular tachycardias. So this patient, we can see, this is not typical of V1. We can see an R wave, which is not typical of typical RBVV, and R2S ratio is more than less than 1 in V6, suggestive of ventricular tachycardia. This patient needs immediate cardioversion and further management. So people tend to, like I said, when you see a wide complex tachycardia, you should shock. But that is not always true. There are few differential diagnoses in wide complex tachycardia where you can go, like they could be benign, not benign, we could go little less aggressive. Few of them is when you see an SVT with aberrancy. In the ECG, it looks like a wide complex, it is a wide complex tachycardia, but it looks like a typical LVEV where there is left axis deviation, V1 to V2 normal transition. So it looks like a typical LVEV. So this patient is having underlying LVEV and developed SVT. So it is an SVT with underlying aberrancy. And this also, you can see pacemaker spikes. So just because he is having a wide complex tachycardia, you should not intervene. This is a pacemaker mediated tachycardia going on. You should change the pacemaker settings to revert back into the normal pacing. So when you identify pacing spikes and wide complex, should think of pacemaker mediated tachycardia. So I'll say many a times when you see this ECG, you think it's a sinus tachycardia. And the clinical history also was saying like patient is having failure symptoms, previous history of ischemic cardiomyopathy. But if you observe closely in the lead 2, there is not a typical sawtooth pattern, but there is a little inconspicuous PVS marching through the QRS. So we followed the ECG. We did a half standardization, mean increasing the voltage. Half standardization, increasing the voltage. You can see the standardization, it is 5 millimeters per millivolt. We try to increase the voltage, but still the PVS, we have decreased the rate by giving amiodarone. So the PVS are now a little evident. So what we did next, a different placement of leads. This is called ECG Lewis lead placement. Now we can clearly see the PVS in 2-3 AVF leads. This is a typical counterclockwise flutter. So this is how Lewis leads are placed. You remove the RL lead and place over the manubrium, and left arm lead over the lower part of the sternum, and left lower limb you place it from the right. From left you place it on the left, right. So this is to make the PVS more conspicuous. So this ECG is seen in patients with WPW syndrome. This is pre-excitation, you can identify, like I said previously, delta wave and white QRS. And since it with fast ventilator, pre-excited. Many times you see this ECG as sinus bradycardia, but you can see two PVS with the 1 QRS, so it's a 2:1 bradycardia. Thank you.
Now, moment of presentation for Dr. Surya Prakash Garu.
Lights on.
Next, we'll start off with the grand quiz.
So the participants for the quiz kindly come on to the desk. Be quick, we are already late. Here you can come over here, your team member will be here. So, 1, 2, 3, 4, 5, 6.
రైట్ వెనక్కి వేసుకోమని ఇట్లా తీసుకోమని రైట్ సైడ్ వేసుకోమని చేసుకోండి. మీరు ఇంకొంచెం పెట్టన్నా పెట్టేసి కూర్చుని పో. Right.
So we have 5 teams. So the 5th team will be audience. Okay. So Dr. Madhu will score the audience also. Okay, let's start our quiz. Lights off, please. Obviously, we don't expect them to see the phones. Except for the buzzer round, don't take your phones out, please. When the buzzer round comes, I will inform. Please keep your phones inside. I told you, 1, 2, 3, 4, 5, 6. Yeah, fifth team is audience. Okay, we'll start off because we're already late. Okay, no mobile phones, please. It's okay. Don't worry if your answer is wrong. Okay, even our FFR societies are wrong. Okay. So there will be 6 rounds. I think I have cut short 1 round. So there will be 5 rounds. Echo round, trials round, cardiac grid round, buzzer round and rapid fire. Okay? Team 1, introduce yourself.
Dr. Saran, DNB resident from Ramesh Hospital, Guntur.
Dr. Harita, DNB Cardiology, Ramesh Hospital, Vijayawada.
Team 2.
Dr. Parvez Nawaz, DM Cardiology resident, Karnool Medical College.
Dr. Srikanth, Karnool Medical College, DM Cardiology.
Team 3.
Dr. Divya, DM resident, NRI Medical College.
Dr. Anil, DM resident, NRI Medical College.
Team 4.
Dr. Sai Kumar, NABH Hospital, Guntur.
Dr. Finny, Cardiology PG, Ramesh Hospital, Guntur.
Team 6.
Myself, Dr. Saina, cardiology resident from Ramesh Hospital, Vijayawada.
Dr. Prin, cardiology resident, Ashtar Ramesh Hospital.
Okay. So there will be 5 rounds. Just a second. We'll directly start off from the echo round because of the want of time. So probably we'll give 20 marks for the correct answer. There is no need to marking, right? We'll start from team 1. That is Dr. Sarang and Dr. Harita. Okay, there is a 13-year-old female with facial rash, bilateral polyarthralgia, proteinuria, cytopenias,
and dyspnea on exertion for the last 2 to 3 months. And this is the echo. Speak something. It's okay. What are findings you are finding there? Start saying what is the view. What should be quick.
Parasternal long axis view.
Oh, okay.
Mitral regurgitation.
What? No. Tell the morphology of the valve.
Thickened leaflet.
Okay, thickened mitral valve leaflets. I'll show you the other views.
Probably ligament sacks.
Sorry?
Ligament sacks endocarditis.
I think can you tell something about ligament sacks? No, in which condition is it seen?
SLE, sir.
Okay, why do you think this is SLE?
So patient is having rash, polyarthralgia, and cytopenias.
Okay, and what do you see on echo also, this pericardial effusion?
Yeah, there is a thickening of the anterior mitral leaflet.
Both leaflets are thickened.
Yes, sir.
I think we'll give the answer, but the exact answer is SLE valvulopathy. See, ligament sacs endocarditis is where you see vegetation-like, varicose vegetation-like structures. The specific entity of SLE valvulopathy is known as ligament sacs. This is a ligament sacs endocarditis. In fact, actually the most common presentation, valve presentation of SLE is thickened valve leaflets rather than ligament sacs. Hardly we see ligament sacs actually. Okay, anyway, we give 20 points to them, team 1. Okay, I'm going on to the second one. Yeah, 31-year-old female to team 2. Gravida, dyspnea on exertion for the last 2 weeks. Grossly unremarkable CVS and respiratory system examination. I'm showing the echo image. Describe the findings. You'll have to describe. You should start.
So this is a parasternal long axis view showing thickening of the chordae tendineae along with the anterior mitral leaflet, which is doming, most likely due to the mass effect.
Sorry?
Due to the mass, thickened mass, which is appearing.
What sort of mass is this? Can you describe the mass?
Seems like a cystic mass.
You should be louder.
Cystic-like.
Yeah, cystic-like mass on leaflet. What is it? What is the most common cystic-like mass on leaflet? You're close. I think. Yeah. For the want of time, we are not passing the question. So, we can award you half probably, but not full. So it says cystic-like mass on the
Hydatid cyst can be it.
What?
Hydatid cyst can be it.
Hydatid cyst. Good guess, yeah. But this is actually a blood cyst. Blood cyst is a known entity where you find cystic-like mass, especially on the mitral leaflets. And the incidence is slightly more in pregnant females. And usually they resolve off. Except some cases, if they're large enough, they might cause obstructive features, or rarely outflow obstructions can also happen. I think we'll about 10 points, not 20 for team 2. Dr. Madhu? Yeah. Okay. So, blood cyst. Team 3. You are seeing an M mode. Identify the specific arrow pointed out there. What is it and what does it signify? You can describe it. It's a mitral valve M mode. No, you can describe what are the waves seen on M mode of mitral valve, antermitral leaflet. What are they known as?
There is a diastolic dipping.
Sorry, you should be louder.
Diastolic dipping.
Sorry, louder. You're
diastolic dipping.
Diastolic?
Dipping.
Sorry?
Dipping.
Diastolic dipping. Can you, otherwise, if you can't tell the word, can you describe when it occurs? What is the first wave? What is the second wave? Can you say anything? On an M mode or in Doppler, what are the waves? Pulse wave Doppler waves. What are those? The mitral valve inflow pulse wave Doppler waves are E and A. So you have E wave, A wave, and there is something there. 5 seconds more. Yes or no? No? Okay, anyone else can, you will not get points, but anyone can answer? Audience? Yeah, D bump. No points for team 3. So it's a it signifies diastolic dysfunction. It is known as D pump or an AC shoulder. So it's seen in diastolic dysfunction when the LVEDP increased. I'll not go deep into it. Probably we'll go on to the next question, but go home and read about it. Okay, team 4. No prize for the audience. No, there is an audience round. 5th question is audience round. Okay, team 4. You are able to see? Yeah. Patient post valve replacement. What do you see?
It's a four-chamber apical four-chamber view.
Louder.
It is apical four-chamber view. You can see the prosthetic valve in the mitral valve. With increased gradients means you have to see the gradients there. It looks like...
You'll have to be louder. See, the answer should be clear. What's...
It's a prosthetic valve in the mitral valve, sir.
Right.
It looks like stuck mitral valve.
Where is it? No.
There is a paravalvular leak, sir.
Yeah, exactly. No. What is it? What is this entity then? What are you seeing? Is the valve okay on the lateral annulus? Louder, please.
Looks like valve got detached from the post.
Yeah, what is it known as? Tell the word. You're right. Valve
got detached from the posterior.
Valve
dehiscence.
I think we'll give it off. It's valve dehiscence.
Valve dehiscence. That's what we said it, sir.
Yeah, okay, fine. We give off plus 20 to team 4. So, okay, the audience question probably an easier one. So, M mode across is seen. What is the diagnosis? Only M mode diagnosis. I don't want anything about the mitral valve. Audience question. Sorry? Huh? No, what do you see on the M mode across the aortic valve? First thing, you can see the valve is thickened, right? And obviously the excursion should be till the point of aorta, right? So there is a decreased excursion of the aortic valve with thickened valve leaflets. It's with something on the mitral valve which looks like rheumatic. So there is also an associated aortic stenosis, right? This is an aortic stenosis M mode, right? Team 6. Slightly difficult one, I guess. Okay, what is seen there? So, Doppler signal across mitral valve is shown. What is the abnormal finding you are seeing there? Are you seeing something there? Something abnormal there in the Doppler signal? Can you describe it? Yes or no? No? Anyone else? Yeah, T2?
Reverberation artifact.
Reverberation artifact. Is there any specific sign which it is known as? And when is it seen, reverberation artifact?
Other disturbances like
what?
Lungs and
metallic
valves. Why would it be seen on a mitral valve? Not you are speaking of A-lines in lung ultrasound. But what is this?
When there is metallic valves, it shows.
Sorry?
When there is any prosthetic metallic valve.
Okay, it's more often seen when there is a flail valve or a fluttering valve. This is known as zebra stripe sign or as a tiger stripe sign. You can see, no, the stripes. They're called as tiger stripe sign or zebra stripe sign. So no points for team 6. Okay, scores please. End of first round. Scores. Team 1 plus 20, team 2 plus 10, and team 4 plus 20. And audience don't have score. Huh? You have 20? B-bump, yeah. No, B-bump. No. It's only for question 5. When your team 5 question comes, then only you will be awarded points. Right? Okay, tiger stripes. So we'll move on to cardiovascular trials round. Right, slightly easier trials only. Okay, team 1 ready? Team 1 ready? Okay. We are giving all the clues. You just tell the diagnosis. So 67-year-old retired school teacher with stable angina walks daily but gets chest tightness on climbing stairs. Stress imaging shows moderate anterowall ischemia. He is on maximum medical therapy and doing well. Which trial supports not rushing to revascularize him? I think the easiest question of all. No, you can't take time. 4 options only. Speak.
Courage try.
No, it's okay, we will not give 90 marks. Oh, I see moderate anterowall ischemia, medical management. So anyway, you will not be awarded points. If at all, if you are given a chance, what else you will say? Second option? So okay, no points for the team 1. Okay, fine. Okay, team 2, ready? Yeah. So 80-year-old woman enjoys gardening and brisk walking. She has symptomatic severe aortic stenosis. Oh, sorry. What is it? So symptomatic severe aortic stenosis, but is otherwise fit with low surgical risk. Her children ask if TAVR is a safe alternative to surgery. Which trials provides reassurance for TAVR in low risk population? Partner 1, Satavi, partner 3, Notion. Team 2. So you should be quick. The options are given to you. 5, 4, 3.
C, partner 3.
Partner 3, right answer. Yeah. Team 2 gets 20 points. Obviously, partner 1 is for the prohibitive risk population, right? Satavi is for moderate risk. Right. Okay, partner 3 is right. Team 2 gets 20 points. Team 3, a 60-year-old diabetic woman with previous PCI is on metformin and statins. Her HbA1c is under control. LVEF is 35. She has class 2 dyspnea. You discuss additional medications that could protect her heart, not just her sugars. Which trial supports this approach of SGLT2 inhibitors? This is also easy one. Should be quick. 5, 4, 3, 2.
Empiric outcome trial.
Yeah. Empiric outcome is the right answer. See, Flowerma has nothing to do with this. No? Flowerma is FFR trial advance. Advance is a registry, advance is for renal outcomes. Team 4. A 55-year-old banker with prior MI is on high intensity statin and estimate, but LDL remains at 85. He is anxious about the recurrence and asks, is there anything stronger? Which trial supports use of PCSK9? Canvas, Fourier, Spire, Max.
So Fourier trials.
Yeah, right answer. Team 4 gets 20 points. So, see one thing, I wanted to tell about Spire. Spire is also a PCSK9 trial, bococizumab, but it was stopped in between because of safety concerns. Right. We'll move on to Team 5, audience. A 65-year-old man, 6 months post-MI, has no angina but persistently elevated HSCRP. He reads online about inflammation being the new frontier and asks if any anti-inflammatory drug can help him. Right, campus. Audience get plus 20. Okay, fine. I'll move on to the next. Team 6. The 58-year-old man comes for L2 PCA. The fellow prefers femoral access for better backup support, but the patient says, my cousin had it from the wrist, less painful and faster recovery. Which trial strongly supports radial access for safety and mortality? Team 6. Matrix, ischemia, safari STEMI, and validate sweetheart. Five, 4, 3, 2.
Matrix.
Yeah, Matrix. Yeah, Matrix is the right answer. Safari STEMI also did not actually show that radial is better, but Matrix was the one which showed. Right. At the end of round 2, what are the scores? Team 1 is on 20. Team 2 is on 30. Team 3, 20. Team 4, 40. Team 5, audience 20. Audience 20. Yeah, only that you'll get. B bump is just a past question. And team 6 gets 20, right? So this will be a cardiac grid round. So I'll be showing a grid and each of you should choose the question, right? I'll show you the grid and I'll tell the rules. So this is the grid. You're able to see ECG plus 20, ECG plus 40. Means you'll have a question on an ECG with 20 points. And ECG 40 means you'll have an ECG question of 40 points. Similarly echo, similarly angiogram, similarly try my luck, which can be anything, right? And there is a surprise also, okay? And there can be a question on intravascular imaging. And if you're brave enough, you can answer a 60 marks for the brave. And if you really don't want to answer, you can skip the chance, right? And shall we give negative marking? No, we'll not be avoiding negative marking. Team 1, choose your grid. Choose one.
ECG 20.
ECG 20, right? I'm going to ECG 20. Ready? 65-year-old male with pyrexia of unknown origin is being evaluated for PUO. And his ECG is this diagnosis. Describe the ECG.
Imperial wall MI.
Describe the ECG.
ST elevation in imperial lead.
ST elevations in?
2-3 area.
2-3 areas, okay. Okay, I'll say that the patient doesn't have any chest pain. He is having pyrexia of unknown origin. He came for evaluation. Okay, I'll show you the baseline ECG also. This is his baseline ECG, okay, which was taken after 10 minutes. He doesn't have chest pain, again I'm saying. No chest pain, and this is the ECG.
Bruca.
Bruca, no. Anyone else? I think Mr. Johnson. Team, anyone else?
Security prolongation is there.
Okay. Audience? Audience? No chest pain, no symptoms. He just came, PUO evaluation, he's being evaluated, and on routine evaluation, an ECG was done. They got scared and they did the repeat ECG. Sorry? No? Huh? Yes, exactly. It's a pulse arterial tapping artifact. When you put a lead over a very bounding pulse, probably his fever might be having a high pulse pressure, and when the ECG lead is put over it, you get arterial pulse tapping artifacts. This has been well described in the literature as well. These are other examples. Okay. Yeah. Team 2, your grid. Once again. Dr. Krishna. Team 2, choose your grid.
Echo 20.
Echo 20, right. Okay. Easy, probably. Diagnosis. It's playing, right? No?
Can you play?
Just a second. I'll try to play it again.
It's aneurysm of the sinus of it.
Just an aneurysm?
It is ruptured.
Ruptured sinus, because you have the right answer. So what? It's 20 plus 20 for team 2, right? Okay, we are moving back. Team 3, choose your grid.
Imaging, intravascular.
Intravascular imaging? What? 20, 40? 20. Fine.
Okay, can you go for 40?
No, you can't go. Once you have entered the grid, you can't exit. That's how I made my PPT, sorry. Yeah, okay, fine. I'm going on to the question. So this is the angiogram, and I'll show you the OCT. Diagnosis. So the OCT has been done for the LAD. Describe. See, I'll award you half points if you describe it at least. You want me to play the OCT again? Yeah. Describe the OCT. Anything you're seeing, anything abnormal there? Yeah, please. See, you don't have time, please. 5.
Honeycombing.
Yeah, exactly. Right. You get the marks. So it's a honeycombing. See, the LAD was showing haziness. This patient actually presented very late, like 1.5 to 2 months later, to a typical chest pain episode. And the LAD looked hazy, so just to evaluate the haziness, we have done OCT. And it was a recanalized thrombus, honeycomb appearance or lotus root appearance. You get 20 points, team 3 gets 20 points. Right. Fine. Team 4, choose your grid. Team 4. ECG 20 is already over. Angio 20. Yeah. Ready? Tell the complete diagnosis. Simple one. Oops. Oh, wait. Yeah. Even I mistakenly put the reference also. Yeah. But I think I haven't asked this one. Yeah. No, what? Describe the left angiogram and the right one.
See, the right image is a RAO caudal.
I don't want the views and all. Just tell something if something is abnormal and
First
go
one
ahead.
is angiogram of a post-CABG patient, sir.
Okay, fine. See, you should be quick. What is the course of this vessel?
It's aberrant origin.
Aberrant origin of what?
Of.
No prompting, please. See, 3, 2.
L6, sir.
Yeah, L6. Aberrant origin of L6 from
right. Right coronary cusp.
Right, fine. I give the answer. I give the marks. On the left side, you can see that there is no L6 in the groove, right?
Yes.
There is only LAD and ramus. They get the points. There is a lesion in the L6 as well.
20.
See, your colleagues are actually saying that you should not be getting full points. So probably we give you a half plus 10, right? Okay. Okay. Plus 10 to Lalita Hospital. Yeah. Okay. Team will come later to the audience. No, those will be kept. Team 6, please. At the end, whatever is left, all audience can answer. Yeah.
Primal luck 40.
Primal luck 40, right? Okay, ready? Identify these people. Any one of them, at least. Any one.
Villain?
Who? Villain, no. Five, 4, 3, 2, 1.
Brooke.
0. Over. Your timer? No, you should identify this guy, no? Huh?
Antius frenzy.
No hand on your column. Huh? No,
Last
the
one.
middle guy is Andreas Grenzi. Huh? No, there's no passing. There's no passing of question. I'm just asking the audience.
Sir,
The middle
I
guy.
answered it, sir.
When did you answer?
Sir, Andreas Grenz.
No, you should be loud, no? See, after everyone answers off, you can't say. You should be loud. Sorry, I can't give you points. You should have told it clearly.
First angioblast.
Huh? No. Now we will not be awarding you any points, right? See, you should have been these guys will fight with you again. Okay? So, I'm going to Huh? I'll show you once. So the middle guy is Andreas Brunswick. Sitting in the front, this fellow is Myler, who actually has done the angioplasty along with Brunswick. I don't know the third person. Some guy, I don't know who is it. Some name. Right, fine. Yeah. We'll come back like this then? Yeah, you have the chance again. So 6 are over, right? 1, 2, 3, 4, 5, 6. Audience are, see, once the rounds are over, you'll have 2 left. There are total 12 questions, right? You can start there. Choose your grid.
For the braves.
Huh? Be loud. What?
For the brave.
Huh?
For the brave.
For the brave. Known hypertensive, unresponsive in casualty, call for ECG opinion. Name this phenomenon. Don't tell me anything. Name the phenomenon. Describe the ECG. Or describe the waves.
Junction.
5, 4, 3, 2. Is it a ventricular rhythm? See the equations, they are very narrow, no? How can you call it a ventricular rhythm? 2, 1, 0. Anyone in the teams? Just the phenomenon name. Nothing. Huh? Ashton? Sorry, I don't find any Ashton. From the audience? Pull in. Someone was saying it's escape capture by Germany, right? So there is a junctional escape and there is a capture. I'll show you the junctional beat. See, no T wave, a junctional beat, and then you can see an atrial echo because of the junctional beat, and then this echo has captured the sinus. So the escape and capture, and it is a bigeminal rhythm. So it's called escape capture bigeminal phenomenon. And can anyone guess the etiology of this escape capture bigeminal? Dr. KP? Etiology of this escape capture bigeminal. Some clues are there in this ECG. Your T waves are tall tented. So basically this is hyperkalemia inducing escape capture bigeminal. So if you see the ladder diagram, so there is a junctional beat which is getting conducted, and then there is an atrial echo, and then this is getting conducted, and then the bigeminal pattern is repeating. So secondary to hyperkalemia. Sorry, brave, you couldn't. So team 4 again, they don't get any points. Team 4.
What are left?
You should be knowing, you are calling it up. So there is no ECG 20, there is no ECG 40, there is no echo 20, there is no angiogram 20, and there is no intravascular imaging 20, and no further there.
Angio 40, angiogram 40.
Angiogram 40. Okay. Not so difficult question actually. Fine. Just tell the diagnosis, don't tell me anything else.
There is occlusion in the descending aorta, and
30-year-old female. 30-year-old female. Yeah, you get the point. Yeah. I think they get it. Plus 40 for team 4. Right? So you can see isolated left main ostral stenosis. In a non-dominant RCA also you can see the ostral stenosis. And then a midline aortic syndrome of Takayasu. Right? Team 3.
Intravascular imaging 40.
Intravascular imaging 40. Right. So you can see the angiogram, right? Okay. There is some abnormality in the angiogram, and for evaluation of that abnormality, intravascular ultrasound has been done. Identify it. Carefully see the iris. I'll give you 20 seconds more for you because iris is long run.
This is fibrolipid block.
Sorry?
Okay.
Sorry?
So you want to describe us the image or?
Describe both. Even if you say the diagnosis, that's enough. Or describe it. What does the angiogram show?
Left main stenosis is there,
right.
osteal stenosis
Okay, fine.
is there.
So you got it there. Now tell me the iris finding of the same.
So a lot of calcium is there.
Be specific.
Can you stop your left main osteal?
You want me to play the left main again? Right? I'm starting at left main. Again, screen is off, please. This is the final graph.
So there is a calcium nodule is there.
Yeah, exactly. Yes. So left main ostium actually shows stenosis and eccentric stenosis. So for evaluation of the same, we have done an iris which actually showed us. So you can very well see the at 11 o'clock to 12 o'clock position a nodular calcium. Right. You get the point. So intravascular imaging 40, they get 40 points. Team 3 gets 40. Okay. Team 2.
Echo 40.
Echo 40 is not over. Okay, 27-year-old male, palpitations for 3 months, systolic murmur at the apex. Okay? See, this is the case scenario. I'll have to show you the echo, right? Okay? Sir. So, but the way the nodular calcium is protruding into the lumen, extrinsic compression, and the same side you are having a nodule is a slightly unusual thing. Yeah, but if you had we not have the intravascular image. Yeah. Okay. Further knowledge. Yes. So when you have such type of foster stenosis, you will have to think of extrinsic compression because of whatever PAH or pulmonary artery dilatations or some mass. Right. So you have a young male who has palpitations, systolic murmur at the apex, and this is the echo.
Which view is this?
Don't ask me for the view. This is the maximum which I could get. So
single ventricular physiology is there.
Wait, not a cyanotic patient, no congenital heart disease, no cyanosis. That's what I can say. Yeah. Okay. Systolic murmur at the apex, and okay, I'll also tell you this is the mitral valve, right? I think I can't show you anything else. Describe something. I'll try to give you some points. Describe something. Okay, there's a mitral valve here. What do you see?
So extension from the interventricular septum is there. Which is a plaques. Then
actually, you can, consider this as a two-chamber view. Now see. Not not exactly two-chamber view because of the whatever pathology is there, getting a proper
It's
view
a
was not
cavity
at all
is there
possible.
on the lateral aspect, which is a maybe a ruptured, which is
Sorry?
maybe a ruptured LV one thing. This is a young patient.
Young patient, palpitations and systolic murmur. I will tell you that systolic murmur is MR only.
Okay.
You were near, you can continue with your discussion, whatever you are saying.
The infected endocarditis can rupture and infected endocarditis rupturing abscess formation can be one thing.
And what has
severe
happened?
MR. And
So what is the location of this then?
Location is the
what is the valve?
Aorta is involved.
No.
Aortic valve.
Why would it cause mitral regurgitation?
So vegetations can be there.
No, not vegetation. I'm seeing. You are saying the rupture, right? And what do you see? What is the structure you're seeing? And there is a communication.
I think it is dissection.
Dissection.
It's not.
See, I'm saying this. See, okay. Because of the view, I'll also tell you. This is LA. This is LV.
Yeah.
Okay. And this is mitral valve. And you can see some communication.
Yes, communication maybe septum. It is one thing is the nearby septum. If it is a two-chamber, RV comes this side. So, unlike.
There's nothing to do with RV. This also will tell. At least tell me what do you see here peripherally and the here.
There is the echogenic opacity inside the cavity.
What can it be?
It can be if it is a ruptured. It can be abscess. One thing, so infected. One thing. And
see, I think I'll give you half points. Right? I was just expecting you to tell the name, but since the view is this is the best view which we could get, so probably I'll give you half points to you. This is submitral aneurysm. I'm telling you, MR, and I did not give you any history of fever or anything.
Views are different.
Yeah, I probably accept even other views also. I was not able to get any other thing. So here you can see that there is an MR and there is a thrombus there peripherally, which is also communicating. Right? Okay. I think you get 40 marks question. You get 20 plus 20 probably. Yeah. And the final question goes to, and we have done also CT, you can see the same. It's a long-standing submitral aneurysm. You can see that the aneurysm actually has calcified also. So there is a thrombus and calcification of calcified submitral aneurysm. Last question.
Left is, I think, trimal.
You want to skip? If you want to skip, you can skip.
Trimal 40.
Trimal 40 is over. Or you can skip your chance. You can happily go off the next one.
20. Okay, so 20 will take.
What do you want? Skip the chance.
20.
Lucky you actually. Because there's no question, you get 20 points. Fine, right? So at the end of this round, and what else is left for you? So skip the chance is what is left for the audience. So and ECG 40 is also left. And I think this has already been discussed previously. What is the diagnosis? Specific sign? South African flag. So I was just saying that he has spoiled the question. Fine. So this is the end of grid round. And the scores are?
Team 1 40. Team 2 70.
Nice. Okay.
Team 3 80.
80.
Team 4 90. Team 6 20.
Team 6 20. Okay. Oh, I'll have to go through my. Okay, we move on to buzzer round now, right? Okay, what we'll be doing is, I think I've already mentioned you, just I'm creating a room, so whoever presses the finger first would get. Just a second, don't join. I'll be the host. Yeah, now join. You have joined? All of you have joined the link? Okay, I'll share you the link again. So what we are trying to do is, so there are buzzer apps or soft websites. So I'll be the host and they'll be joining the buzzer, and whoever presses the buzzer first will be given the chance, right? Now, yeah, this has negative marks right away. The buzzer round obviously has negative marks. Audience, yeah, buzzer round, yeah, you can participate if they don't answer. Please don't buzzer first. Anyway, you don't have the links. Right? Everyone has entered? No. You enter your team 1, 2, 3, 4, 5, 6, 7. Okay? Right? Don't buzzer, please. Don't press the buzzers. Everyone has entered. Please affirm. Yeah? Everyone? Kindly tell. Where is it? Huh? Team 3? Team 4? Team 4? Team 6? Everyone is ready? Okay? 3, 2, 1. What is the device? Press your buzzer. Whatever. So team 2 gets the buzzer. Okay? Team 2 gets the buzzer. You should immediately answer. You should immediately.
Yes, pacemaker.
Sorry?
Subcutaneous pacemaker.
It's not pacemaker?
No, sir. It is a tandem heart.
It's not a tandem heart. You get negative markings. -10. The second in the line is team 6. Team 6, you'll be getting a negative mark. Tell sir. Time out. Next is team 3. See, you have only 2 seconds. Time out. Team 1. What I exactly, subcutaneous ICD. You can see the lead. No, that's an ICD lead. You'll have to see the, you told subcutaneous pacemaker. See the lead, a thick lead there. It's not a subcutaneous pacemaker, it's a subcutaneous ICD. At your level, we don't expect you to tell just the device, right? Okay, fine. So who? See, whoever has buzzard will get negative markings, even if it's time out. Team 2 gets negative mark. Team 6 gets negative mark. Team 1 gets negative mark. Not you. No, only 2 teams get negative mark, right? -10 plus 20. So, see, plus 22, your team, right? You have answered, no? You have answered, no? Sorry, I'm sorry. So, team 1 gets plus 20. Team 2, team 6, team 3 gets -10. Score bearers, okay? Team 2, 6 and 3 gets -10. And team 1 gets okay. I'm resetting the buzzer. Okay? Don't press your buzzers. It's ready? Are you ready with the buzzers?
We don't need to log in again, right, sir?
Sorry?
We don't need to log in again, right?
No need to log in again. I have reset the buzzer. You just need to press the buzzer button, right? Okay? Ready for your question? What is the device? No, wait. Let the buzzers be over. Okay. Team 6 gets the first buzzer.
Capsule shape, leadless pacemaker.
Right, you get the answer, right? Fine. Team 6 gets plus 20. Okay, I'm resetting the buzzers again. Okay. Ready? 3, 2, 1, go. Diagnosis. Diagnosis. So team 6 has pressed the buzzer. Sorry? What did you say? I was not able to hear. See, you'll have only 3 seconds. 3, 2,
myocardial bridging.
No, sorry. Team 6 gets -10 and the second team is team 2.
Air embolized.
Yeah, you can see the air bubble. An air bubble going all the way down. Okay. Team 6 gets -10 and team 2 gets plus 20. Okay. Ready for the next question? So, I'll tell you the history before showing the question. So, this is a 60-year-old female. A stent was put 1 month back, and now she undergoes some surgery. Diagnosis.
Stent infections. Sorry.
Why did you answer? No, I should. Team 1 press the buzzer first. See, if it repeats again, you'll be getting minus marks for this. You cannot answer. Team 1 press the buzzer first. Okay, fine. What shall we do with the audience? Can you tell what shall we do with this question? Right? Because team 1 gets the disadvantage because of that, no? They might be knowing the answer. Fine. I'm skipping the question. See, if this repeats again, you'll be getting negative points for that. Yeah. But they did not yet answer, sir. But they have heard the answer, obviously. But I don't think, probably they might not be knowing the answer also. Yeah, probably. I think that's fair enough. Because, see, this is your last warning and team 1 gets 20. Team 1 gets plus 20. And team 6 issued a warning. Fine. Okay. I'm resetting the buzzers. Okay. Ready? No one answers till I say. Okay. So, as per buzzer, again team 1 has pressed the buzzer first.
Dr. Cherian.
Right. Plus 20 for team 1. Fine. So, I'm resetting the buzzers again. Now, this is a 35-year-old male, comes with some atypical chest pain, right? I'm showing an ECG. Diagnosis. Okay. So team 2 has pressed the buzzer. See, you don't get time. Once you press the buzzer, you will have to answer.
Yeah, artifact.
What artifact?
So, motion artifact.
Motion artifact, right? It's a motion artifact. Lead 2, you can see clearly it's normal. It's not some VT or EF. Nothing is there. Fine. Team 2 gets plus 20. Right? Okay. It's a motion artifact, of course. And okay. Ready for the next one? I'll show you an instrument, and based on the question asked above, you'll have to answer, right? This is the instrument, and what is the answer? Okay. So team 3 has pressed the buzzer. 5, 4, 3, 2.
Rotabar and nitrogen.
Huh?
Nitrogen.
Nitrogen, right. You get the answer. So team 3 gets plus 20. Right? Resetting the buzzers. And I'll be showing a device. Tell the device and tell where it is used. Three, two, one. Time out. No one has pressed the buzzer actually. Oh, I think wait. Team 6 has pressed the buzzer. Yeah.
Renal denervation.
Right. It's a simplicity spiral catheter used for renal denervation. You get it? Okay. Right. So next ECG is being shown. It's a 35-year-old male who comes for general health checkup. Diagnosis. Okay, team 4 has pressed the buzzer.
Reversal of leads.
Sorry?
Reversal of leads in lead 1.
Reversal of?
Reversal of leads. Limb leads.
Reversal of limb leads. Can you describe it more?
Lead reversal, sir. AVR QRS is positive.
Yeah, you get the answer, right? Correct answer. Team 4 gets plus 20. Can you be more specific? Which leads are reversed? It's okay.
LAR.
Okay, I'm going on to the next question. So, I'm showing an angiogram of an elderly lady who presents with sorry? Oh, sorry. Yeah. I've reset the buzzers. Okay. I'm showing an angiogram of an elderly lady who presents with atypical chest pain. What is the diagnosis of the coronary angiogram? I don't want the other findings, right? Okay. Team 6 has pressed the buzzer. I'll play again, yeah. Team 6.
This mitral annular classification.
I told you I don't want the other findings. I want the findings of only coronaries. Fine. You get -10. Team 2 has pressed the buzzer. 5, 4, 3, 2, 1.
Collaterals.
Huh?
Collaterals.
No.
The bridging is there in the PDA.
Exactly, right. So you can see PDA myocardial bridge, right? Team 2 gets plus 20.
They got 2 chances.
Huh?
They got collaterals and then
Sorry?
they modified the answer.
So, what shall we do? What does the audience say?
Along with it,
What shall we do with it? We award half marks to them. So team 2 gets plus 10. Right? Okay? Ready for the next question? Buzzer is reset. So 50-year-old male with atypical chest pain. I'm showing an angiogram. I'm showing an OCT. Just answer the question asked. You need not answer other things. I'm again repeating. Just answer the question asked. I'll show you angiogram. I'll show you OCT. Right? Don't be in a hurry. Don't be in a hurry. Team 3 has pressed the buzzer, right? 5, 4, 3, 2, 1. Okay, team 3 has pressed the buzzer. What is the percentage area stenosis?
So minimal human area 2.3.
What did I ask?
Percentage.
Then tell only the answer the question. 5, 4, 3.
50 to 60%.
Huh?
50 to 60%.
50 to 60%. Wrong answer. Team 3 gets minus. And team 2. Next.
65%.
65%. Minus 10 for team 3, minus 10 for team 2. Okay. It's playing? No? Okay, fine. I'm playing again. I think I thought of putting this as for the brave plus 60, but somehow it landed up here. Anyone can answer in the audience? What is the percentage area stenosis here? First thing is there really stenosis there? Huh?
Bridging is there.
Exactly. It's a myocardial bridge. There's no disease there. See, once you go into it, it's absolutely plaque free. You can see that the media is thickened at the junction. It's a myocardial bridge captured on OCT. So, for the same, immediately after doing this OCT, I have removed a IVUS catheter to prove the same. So, this is the IVUS of the same patient. You can see that the artery is getting compressed and relieved. And with liberal NTG, huh?
Seems some lesion also there along with bridge.
With the liberal NTG, you can see that the bridge is clearly seen now when a guide catheter was used. So minus 10 for both 2 and 3, right? Yeah. Okay. See and answer. Yeah. Oh, sorry. I'm sorry. Right. Yeah, buzzer is reset now. Okay. Yeah, okay, it's okay. All of them are same. Okay. What is the diagnosis? forgot of putting the post-op image. I should have put it. I have it actually. Anyway, diagnosis. So no one among the teams have answered, and cardiac surgeons should not answer this question. Other than cardiac surgeons, someone please answer. Other than cardiac surgeons, if someone can answer. Huh? Give them a hint, sir. Huh? So what the appearance of it's a CCP intraop CCP picture. Actually, I should have shown. You would have better appreciated it, though obviously we cannot appreciate as much as the surgeons do. But I should have shown the post-op image where you can see the red myocardium seen after this. The pericardium has been peeled off. So no one gets the mark. No one has answered. Right. I go to the next question. See, in this question, I'll show you the series of. Don't answer the question. I'll show you a series of angiograms, and then I'll show you an OCT image. Then you press the buzzers after knowing this, right? So this is a 63-year-old female presented with unstable angina. There is an OM lesion for which OM stent has been put. Okay, and something happened after the stent has been put, and then you get, this is pre. These two are post. Okay, this is the angiogram registered. I'm going on to the OCT now. Again, I'm repeating. A stent has been put for this lesion, and then post stenting. These are the pictures, and then I'm showing you the OCT diagnosis. Right. Just a second. Am I there on the buzzer? Otherwise, I'll wait. I think I've logged out. Just a second. Can you again please log in and see? I'm just putting the link again. I think I have logged out. Yeah, please click the link again, not this. I've put it in the WhatsApp group. Just I've logged out somehow. I don't know. No, I think it is getting logged out again and again. I think there is some time limit for this free trial version. What shall we do with the other buzzer questions? Yeah? Lift of hands probably. But who will be the guys who will be looking after? Yeah? Please, you should be saying who has lifted the hand first, second and third also, because they might not be able to answer, right? It's okay, leave it off. Leave it off. It's all right. I do not. For the question you have answered. Okay, we'll give you this thing. You'll answer, but let the others see first. I did not even play the OCT totally, right? Okay. So this is the angiogram and then OCT. Raise your hands. Okay. Right. They were yeah. Diagnosis. I'll not run it again because diagnosis.
Thrombus along with the distal and restriction.
Sorry?
Thrombosis is there and
where is the thrombus?
In the distal, in the middle to distal part is there. Sir.
Okay. What was the angiogram showing? Was it showing thrombus? Wrong answer. -10. Next is team 3.
Can you play once?
No, I'm not playing. They'll get the disadvantage.
Under expansion.
Dissection, proximal dissection.
Can you be slightly more specific?
Dissection, intracoronary dissection.
Intracoronary.
Intimal.
Intracoronary. What shall we do? Shall we award the marks to them? See, first of all, important point about OCT is not just the running film, you'll also have to see the views. Stent is there till here, and proximal to the stent there is a stenosis. Was there a stenosis to begin with when the stent was put? No, right? That's why I told you to look at the angiogram carefully again. There was no lesion to begin with previously here, and now there is a lesion here. And now on the OCT, there is a new stenosis there, which shows what? What is this?
Dissection.
I can't award you marks. It's an intramural hematoma, right? A lens-shaped half-moon structure seen proximally to the stent. See this? You're able to see from 2 o'clock to 6 o'clock position. So team 2 gets minus 10, team 3 gets minus 10.
Hematoma, it's maybe clot at all.
No, hematoma you are saying inside the coronary artery. This is in the wall, right? After the stent has been put, proximally there was an intramural hematoma which was created, right? Both 2 and 3 gets minus 10. Right, then a new stent has been put. There was a stenosis right there, so a stent has been put. We should be careful while putting a stent to an intramural hematoma, because again that hematoma can extend even more proximally when you put a stent because of the squeezing effect, and if it goes off to left main, then it can be catastrophic. So be careful. Sometimes statine balloon is useful in these cases. Right. We'll move on to the next surgical question again. What is the diagnosis? It's not playing. It's playing, right? Lift the hand. Lift your hands. Okay. Identify the arrhythmia.
Yes.
I did not see. I issued a warning that I should be telling. You'll get minus 10. Team 2 gets minus 10. Team 2 gets minus 10. Obviously, they have answered the question. There's no point more. So obviously, you can see an appendage which is fluttering, right, or fibrillating. Probably flutters. What do you say? Flutter or fibrillation? Fibrillation only, right? Yeah. Figure. No. They have already answered it.
Last time we raised the hand. Last time they have told the answer, but they did not buzz it. They give the point to the next team.
Okay, fine. Okay, what shall we do? Half point? Full?
How we get?
Full points, right? Fine.
No,
Team 3 gets plus 20.
We can't get full points like this. I think
Sorry?
buzzer should be working so that it will be better in this kind of situation.
Okay, fine. Then
So buzzer can't.
we'll go with the buzzer again. Just hold on a second.
Or message to the host, whoever sends first will get first.
Okay, just check once now. I think it is getting reconnected again and again. Just wait a second, not this also. This is also getting disconnected. Just now check. Now check. You have logged in? WhatsApp link has been put. We don't have many buzzer questions anymore left anyway. Okay? Everyone logged in? Huh? Please affirm. You have logged in? You have logged in? Logged in? Team 3 is yet to. Yeah? Everyone has logged in. Right. Who has put it as quiz? It's the number, right? It's okay. Who is quiz here? 1, 3, 4, 6. Someone, the left one is 2. Why did you put it as quiz? Leave it off. No, it is written as quiz. It's okay. Don't change now. Don't change now. Your quiz as of now. Okay, we are going on. So the next question is, what surgery is being done? Okay, 3, 2, 1. Okay, only team 3 buzzed. You'll have to answer.
Looks like a myxoma removal.
Okay, why did they put this? Is there heart there?
Oh, heart transplant.
Minus 10. Minus 10. Minus 10. Only team 3 buzzed, so obviously minus 10. And is there heart there? There's no heart there, no? Okay, fine. Cardiac transplant is being done. Heart has been removed there. Fine. It's called empty cardiac well. Well of. Yes. Sorry? Later. First time they are told, and then I have told the clue. I have written the clue clearly there. They should have read the clue and then answered. No points for them. Okay, 40-year-old male, occasional palpitations, one episode of sorry.
Refresh.
It's okay, yes. Refreshed. Just a second, yeah, refreshed. Okay, 40-year-old male, occasional palpitations, one episode of pre-synchro. Normal LV. Should be quick. No one has buzzed. 3, 2, all should get negative marks for this. 3, 2, 1. Over. Team 6 has pressed the buzzer first.
Amidron.
Amidron. So it is the melanosis caused by amidron occasionally. Rare but can be seen. Okay.
Initially, what did you come?
So you should have told me before that you are logged out. Try to log in again at least for the next question. Okay, I'm putting the link again for your sake. Okay. I think we have only 4-5 questions in buzzer round anyway. All of you log in, please.
I think we should be ending this.
Okay, logged in? Logged in? All are logged in? 1, 3, 4, 2 and quiz. Quiz. You are the one, right? Fine. Okay? Okay? Just tell the diagnosis. Just tell the diagnosis, don't talk. If someone talks, they'll get -10. Till I say, don't talk. Okay? Fine? Team 4.
Brugada syndrome, sir.
Brugada syndrome. Can you identify what are the pictures showing?
What is the question? Brugada syndrome.
What are the pictures showing?
That secondly, first one is the person of second person is Brugada.
Okay. Actually, Brugada are three brothers. And what is the third picture showing?
Prevalence of the Brugada syndrome in that area.
Fine. Team 4 gets +20, right? I think I'll skip up some questions. Okay, fine. Next question. Diagnosis, right? Diagnosis. Oh, okay. Fine. Yeah, buzzer is reset for you all. Yeah? Diagnosis. For the past one? I think I'll end the buzzer round probably. This will be the final question. Anyway, team 4 has pressed the buzzer. 5, 4, 3, 2, 1. -10 for team 4. You have pressed the buzzer first. Team 4 was the one.
No. We were thinking you were talking to them.
Then why did you press the buzzer?
No.
5, 4, 3, 2, 1. -10 for team 4.
criteria.
Team 2.
Aortic dissection.
Aortic dissection. Excellent. Explain.
Stanford criteria. There are 2 criteria.
Yeah,
DBT criteria.
Stanford's classification, chest pain and wide and mediastinum. Aortic dissection. The team 4 gets -10 and team 2 gets +20. Because of the buzzer issues, I think I'll stop off the buzzer round. We'll go on to the next round, which is the last round, which is rapid fire. Okay. We'll get on to the scores. Scores, please. This is the final round. See, I'll explain the rules of rapid fire meanwhile. So, there are no 10 questions. I think there are only 6 questions. Okay, plus 20 for the right answer, minus 10 for the wrong answer, and you can skip the question. Right? You can tell I want to skip the question. Right? There will be 45 seconds. Once you have skipped, you can re-attempt it up. If you have finished all the 6 questions, you can come back and answer. Right? Okay, the timer will start and it will be only for 45 seconds and there will be 6 questions. They are all single liners and the answer should be in the order. You can't answer 6 questions first. Okay, you get the rule. Plus 20 for right answer, minus 10 for wrong answer. You can skip and the skipped question can be reviewed again if you have time left. Right? Scores, please. Meanwhile, I'll show you some more audience questions then. Okay, audience ready? 78-year-old female received some IV medication for heart pain in ER. What is the diagnosis? Yeah, someone was saying. That's okay. Then what's the diagnosis? Which medicine is this? Anyone? So basically, it's been described that recombinant tissue plasmin activator, which is alteplase, has been associated with orolingual angioedemas. Sometimes they can be unilateral as well. So this is that case. Right?
Yeah. Score ready?
Score ready? Yeah, please.
Yeah. Team 1, 100.
Right.
Team 2, 100. Team 3, 80. Team 4, 110. Team 6, 50.
Okay, fine. Right? So how much is the gap between last and first? Gap between the last place and first place. What shall we do for, I want to ask the audience, what shall we do for rapid fire? For each question, the rule is plus 20 minus 10. Shall we increase the points so that even the last place guys can come to first, or shall we put it as plus 20 minus 10 only? Plus 20 minus 10? Right, fine. Okay. I hope you have understood the rules.
Each team will get 6 questions.
Each team gets 6 questions. It will be for 45 seconds. Each team gets 45 seconds. There will be 6 questions. Plus 20 minus 10. You can skip the question. If you have time left, you can come back and answer that question as well. But if you have answered it wrong, you cannot come back and answer it again. Right? Okay? I'll put it on the PPT. So it should be working hopefully. Right? Team 1 ready? See. Team 1 ready? Team 1 ready? Team 1 ready?
Ready.
Yeah. Be attentive because it's rapid fire, right? Okay, team 1. Your question starts. Name one trial related to invasive FFR. See if you can skip the question. Don't waste your time.
Skip.
Huh? You're wasting your time. Skip. Vmax of aortic valve is 4 millimeters per second. What is the peak pressure gradient?
Skip.
Loading dose of rivaroxaban is 15 mg BD for acute PTA for 2 weeks. True or false?
False.
They get the point. Mechanism of action of butyric acid.
Inhibition of ATP citrate lyase enzyme.
Right. Name the condition where Ashman phenomenon is seen.
Skip.
Okay, you can answer whatever skipped you. Time up. Your circle is over. So, okay, name one trial related to invasive FFR. Isn't that told? Some failed trial or something. Vmax is 4 meters per second. What is the peak pressure gradient? 64. You should be answering. Where is Ashman phenomenon seen in ACG? Yes. Okay. So, they have answered 2 questions. So, they get plus 40, but they did not answer any wrong question. So, plus 40. Right. Okay, team 2 ready? If you want to come forward or something, you can. And once I start, I will not get any other time. Right? Okay. Team 2. Loading dose of prasugrel is 30 mg. True or false?
False.
Mechanism of action of alirocumab. Skip. Okay. Name one trial related to CTFFR. You have had so many sessions in the morning.
Skip.
Skip. Name a condition where pressure recovery phenomenon is seen on echo.
Skip.
Skip. What would be the systolic blood pressure in a patient with large VSD and severe AR if the RV systolic pressure is 180? What would be the systolic blood pressure if the RV systolic pressure is 180? Time up. Time up.
Second one. Second one will answer, sir. Alirocumab PCSK9.
Shall we give up to them?
Time up.
Time up? Huh? Sorry. No, they said time is actually up.
Time up.
No, that's what rapid fire means, right? If you answer. So you get only prasugrel question right. So only one correct. So mechanism, anyone knows, trials we have discussed a lot in the morning session. Where is the pressure recovery phenomenon seen? You should be answering this, right? And last question. What would be the systolic blood pressure in a large VSD with severe AR if RV systolic pressure is 180? What happens in large VSD? What would be the LV systolic pressure in this patient?
Equalization will be the same.
It would be the same. So RV systolic pressure 180, LV systolic pressure would be 180. And is there any AS mentioned? No. So then what would be the systolic blood pressure? 180 only. Right, fine. Okay, they get only plus 20. Okay. Team 3, you're ready? Your time starts. Subcutaneous dose of alirocumab is 240 mg every 2 weeks. True or false?
False.
Mechanism of action of ivabradine.
Funny channel blocker.
Right. Name one trial related to low risk TAVR.
Early TAVR.
Sorry?
Early TAVR trial.
Early TAVR, right. Name a we'll see about it. Name a condition where Coanda effect is seen.
Pass.
Pass. What would be the RV EDP in a patient with large ASD if LA pressure is 9?
9.
Right.
Coanda effect will have answer. Aortic stenosis.
Which one?
Coanda effect.
Aortic stenosis. I don't give you total points for aortic stenosis. If you are more specific, you might get. Time up. See, it's seen in supravalvular aortic stenosis or an eccentric mitral regurgitation. It's fine. For classical aortic stenosis cannot be an answer. It is specifically for supravalvular aortic stenosis, right? So you get, first one is right for you, ivabradine is right for you. Low risk TAVR, early TAVR is what they have answered. What shall we do? Shall we give it up? Early, yeah, but it's not according to risk, no? What do you say?
Negative.
Yeah, okay, fine. You get the low risk TAVR also. Coanda effect you did not get, but you got the ISD also right. They get 4 points right. Plus 80.
Sir, Coanda effect we can
No.
aortic stenosis.
See, that cannot be given. See, you should be specific. Aortic stenosis cannot be the answer for
marks
Coanda.
will get right.
No.
Aortic stenosis is.
Actually, they get -10. You're right. I forgot about it. You get
Sir,
-10. Or will not give you negative marks. Will not give you negative marks.
Okay.
Plus 80 for them. Right? Okay, next team is ready? 4. Okay. Dose of bempedoic acid is 180 mg BD. True or false?
False.
Full form of PCSK9.
Skip. I told skip.
Skip. Okay. Dose of icosapent. You should be loud. Dose of icosapent.
Skip.
Okay. Name one trial related to ARNI.
Skip.
Name a condition where pressure. This question is not there, sorry. Next question. What would be the saturation of pulmonary artery if RV and LV saturations are 95 and 72 in a CCTGA patient?
Skip, sir.
Okay. What are left for you? PCSK9. Dose of icosapent. Time up. What is the answer? Bempedoic acid is right. PCSK9 they did not say. Icosapent they did not say. RNA they did not say. This is about the last question. What would be the pulmonary artery saturations in a CCTGA patient if RV and LV are 95 and 72? What happens in CCTGA? What happens in CCTJ? They're not listening. Okay, anyway, what should it be? Just go back and read about these things. These are asked in the questions as well. PCSK9 full form. Proprotein, convertase, subtlysin, Kexin 9. Icosapent dose, improve it, 2 gram BD. Army, if you don't say paradigm HF, it's a crime. That's okay. They did not answer any question, right? They've answered only one. Huh?
First question.
First question only. So plus 20, that's all. Fifth, team 6, you will be answering the team 5 rapid fire, and then audience will answer the team 6 rapid fire, right? Okay, you ready? Loading dose of clopidogrel is 300 mg for primary PCA in STEMI. True or false? Huh?
False.
Okay. Mechanism of action of inclisiran.
Small mRNA which inhibits the protein, which inhibits the synthesis of PCSK9.
Right. Name one trial related to SGLT2 inhibitor in HFF.
Emperor.
Okay, right. Name one condition where Brocken-Burrow phenomenon is seen on hemodynamics.
Skip.
Okay. What happens to mean diastolic gradient of mitral valve in mitral stenosis if the patient develops LV dysfunction? Increases, decreases, no change. Time is up, yeah. Okay, what did you get it right? So loading dose is obviously by current OASS trial, it is 600 mg for primary PCA. Mechanism of action, you told it right. SGLT2 empiric, you told it right. Brocken-Burrow phenomenon. Huh? So why did you yes. Okay, and what happens to the mean diastolic gradient in MS if there is increased LVEDP? What happens to MDG? It should decrease, no? Okay, so how many did you answer? 3. 3 correct? 60 plus 60. Right, for the audience, already? Yeah. Okay, your time starts now. Middle is phosphodiesterase 5 inhibitor, true or false? Initial dose of endosin in SVT, obviously very simple one, 600. Name one trial related to PCSK9. Okay. Name one condition where Gallivandian phenomenon is seen. Easy ones actually. What happens to pressure half time of a patient with chronic AR if he develops LV dysfunction? Increases, decreases. Pressure half time. It should. If the LVEDP is high, then equalization of pressures will happen rapidly. So the pressure half time should decrease. Fine. So that's it. That's the end of our quiz. We'll have our scores, please.
So I'll start with the low to high.
Yeah, please.
110 marks, team 6. 120 marks, team 2. 130 marks, team 4. 140 marks, team 1. So the winner is team 3 with 160 marks.
Congratulations to everyone. Actually, participating itself is a great thing. So, just, sir, is that the episode? We can hand over the certificates. Okay. So, then I'll call upon Jera Pai sir, Shivaprasad sir, Dr. Raja Ramesh, Girbabu sir is there. So certificates will be distributed, sir, if you want. Yep. So tell me 1, 2, 3. Now the descending order. Winners are? Okay. And second place goes to 140. Okay. Okay, right, fine. Okay. All the teams, congratulations. So we'll be distributing the participation certificates, and you also have some gifts from our side, and the top 3 prizes. Okay. Top 4 places will get prizes.
Lights.
We don't know the name. Sorry, you're Shrikant and Ramesh from Kurnool. Congratulations. We'll give up to 6 first. First, Dr. Sainath and Dr. Prem, please come forward. Huh? Right, Sainath is Ival.
Congratulations, Dr. Sainath and Dr. Prem. Keep it up.
Please stay on the podium. I want a final photo with all the participants. Next, please.
Shrikant and Parvis. Go. Congrats to Dr. Shrikant and Parvis. Parvis, you also go. Winners. Congratulations, Dr. Divyan Anil. Dr. Divyan Anil. Congrats. participants stay here only. We'll take a group snap. All participants.
Everyone, let's take this moment to acknowledge Dr. Ram Manohar, the quiz master. Please give a round of applause to the quiz master. He's put an enormous amount of work to make this quiz so amazing for everyone. He's involved everyone in the audience here. Please give a huge round of applause to Dr. Ram Manohar here. So it's a wonderful evening to all of you. It's been a wonderful job done by under cardiology team of Ramesh Hospital and Guntur. Thanks to the KU faculty management for giving this wonderful auditorium for today's event. Thanks so much.
అయిపోయిందా